Good evening, everyone. Myself, Dr. Prashant Gowda, Secretary NNF Chapter Karnataka. We had a fabulous session on July 22nd on the first episode of Amplitude EEG and its clinical applications. So we are continuing the clinical applications and its usefulness beyond HIE. So today we have very interesting topics which will be covered. That is amplitude EEG in a preterm baby, and that happens to be most interesting and fascinating topic for our speaker Judy, and she's already warned us that she's going to get lost. We have to literally, she's going to get drowned. We have to pull her back up to the surface. And it's going to be, I have listened to Judy in our previous conferences. She's a wonderful speaker. Thank you, Judy, for making time in such a busy schedule. So we would like to thank GenWorks and Natus for all the support and the machine what they provided for today's session. So on behalf of NNF Karnataka chapter, from our president, vice president, and the entire team of NNF Karnataka, we would like to give a warm welcome. Over to you, Judy.
Thank you so much for that very warm welcome. And correct, it is my passion of interest, not even just AEEG in the preterm, but the preterm brain and the development of the brain and the neuroprotection that we can actually offer these infants. So yes, this is the second part of the series that we're running. Last week, for those of you who joined us, we gave a very good overview of AEEG as an application at the bedside, the benefits that continuous monitoring can bring us, and we gave a detailed view on how to interpret traces. So to start with, I will actually just recap on that. So remember that when we're interpreting the AEEG trace, there are basically 5 background patterns that we see. That's the continuous normal voltage, discontinuous normal voltage, burst depression, low voltage, and the isoelectric trace. And then, of course, we have the seizure pattern. So that's just a basic recap for everybody on the background patterns that we have when we monitor infants with AEEG. And we talked a lot more last week about interpreting those traces really in the context of the full-term babies. So I'm now going to move into the context in the preterm baby. So again, we're going to launch some interactive polling sessions for you during this event. And my first question to you will be, which essential components of the AEEG trace interpretation do you think it would be relevant when we're interpreting the preterm AEEG? So I'm launching that poll, and hopefully you guys who are there as participants can see that poll, and you should be able to vote. So if anybody wants to put their votes in, what do you think would be the most essential element when we're interpreting the preterm AEG? Is it to describe the background pattern? Is it to describe the cyclicity and sleep-wake cycling? Is it to describe seizure activity? Or is it all of those things that we should think about in the preterm AEEG? So for the sake of time, a lot of people have voted. I'm going to close that poll. I'll share those results with you. And yeah, 80% of you said all of the above, and that would for me be the correct result, and I'll explain why as we move through. So when we're interpreting or assessing recording and the AEG interpretation in preterms, it's the same main steps that we use in the full-term baby. So we're looking at the pattern recognition. We're looking at the percentage of time we have those different patterns. We're looking at the maximum and the minimum amplitude. We're looking to see if the sleep-wake cycling and how mature that sleep-wake cycling is. And of course, we want to see if there's any signs of seizure activity. And the evidence behind the background patterns in the preterm infant really comes originally from the work done by Professor Lena Hellstrom-Vestas and her colleagues, superb paper that was published in Neo Reviews back in 2006. And here, as you can see on this table, they actually looked at infants at different gestational ages, and they looked at the dominating background pattern, whether there was sleep-wake cycling and if that was imminent or immature, or whether it was developed. Then they looked at what the minimum and maximum amplitudes in microvoltage would be in these infants, as well as how many bursts per hour we should expect. And this table kind of signifies at that point what we believe to be normal for these babies, these preterm babies. So bearing that in mind, I have another poll question for you, which is, which of these is considered to be the dominating background pattern in a preterm infant? So let me just, sorry, I just have to go to the next poll. Sorry, just bear with me. Right, so which one of these would you consider to be the dominating background pattern in a preterm infant? So what's there most of the time? We see other patterns, but what would be the dominating pattern in a preterm infant? So again, you can see quite a few people voting. I'll give you a few more seconds just to make an educated guess if you don't know, and then we'll give you the answer. So let's close that poll and I can share the results with you. So actually 12% of you thought the dominating pattern would be continuous. 52% of you said discontinuous normal voltage, a few said burst suppression, a few low voltage, and a few flat trace. Well, I will actually give you the answer to that. So actually the dominating background pattern most of the time for normality in a preterm infant is discontinuous, and it's got features that would have periods of high voltage activity, it would have some bursts, it would have also some periods of low amplitude, but in general the dominating pattern is discontinuous. But this pattern evolves as the infant matures, and this was a very nice paper published a long time ago now, and I look back, it's actually published as I started in neonatology 30 years ago, and the graphics on this show normal trace at different gestational ages. So on the left hand side here we see recordings from extremely preterm infants at 24 to 26 weeks gestational. So you see there a 24-weeker at the top, 25 weeks, 26 weeks. That looks a very normal pattern. There is some rudimentary or immature sleep-wake cycling that we see with that wavy pattern at the bottom, but it's mainly discontinuous. That lower margin is below 5 microvolts. But that is what we would expect to see as a normal pattern. And then as these babies mature, the background pattern becomes increasingly continuous. And that's actually best seen in the lower border of the trace, which gradually starts to increase in its amplitude from the kind of 2 to 3 microvolts you see in the extremely preterm to over 5 microvolts, 5 to 7 microvolts, probably in that sort of 33-weeker there. So we can see also that as these babies develop and mature, we get these quiet sleep states as well. So that sleep-wake cycling is really maturing, and it becomes very evident by the time the babies reach approximately 35 weeks gestation. So this is kind of normality for the preterm infant. We see this brain evolve and develop. So let's think about why. Why does this happen? What's happening with that preterm brain? And let's think about what's normal and what's not normal for a preterm baby. Well, if we think about a preterm baby, actually extrauterine life is not normal. They shouldn't be extra utero. They should still be in utero, where they've got really good placental transfer, they've got acoustic dampening, light protection, they're in this beautiful fluid environment, it's warm and it's moist for them, and they're close to their mother. And that is what nature intended for 40 weeks of pregnancy. That is normal. Yeah. So when we think about the preterm baby, what they are exposed to ex utero is really abnormal, because now they're having assisted ventilation, they've got lines in, we have to give them nutrients, they're at risk of infection, and they're really exposed to all the light and the noise and the pain and the whole stressful experience of the NICU, and we separate them from their mothers. So actually extrauterine life is not normal for these preterm babies. So we want to try and think about what we can do to support them, and think about what's going on with these babies' brains. So while we've got this baby in the NICU, what is actually happening in the background? Well, let's think about brain development. Think about the anatomy, physiology, and embryological development of the brain. So if we think of a baby at 24 weeks, this is probably what their brain looks like. It's very small, it's not so heavy, it's got very little gyral formation, gyral folding within it. And as this baby develops, so the brain grows and folds and develops structurally until we get to the brain that we expect the baby to be born with at 40 weeks gestation. So you can see graphically here, there's a lot of very complex things going on with this brain throughout pregnancy. And if the baby's born early, this brain has got to develop in our NICU environment. It's got to develop in an environment that is not the expected environment for brain development, where we're nurtured and we're quiet and it's dark and we're close to mother, etc. So again, if you look at this depicted in scans, you can clearly see here all the way through from 23 weeks gestation through to term. We see how this brain grows and we see how it develops, okay? But it's not just about structure. Clearly as well inside we've got all of the firing and wiring and everything that makes up this baby's brain. So I have another poll question for you guys, which is, do you think brain development is a linear process? Do you think it just all happens in one linear line? So either yes, it is, no, it isn't, or you're unsure. It's just growing in a linear fashion, or does something happen differently at different points in gestation? So think back to your embryology lessons and let's see what people said. So I'm going to share the results with everybody. And in fact, 71% said no, and 21% of you said yes, 8% of you are unsure, and that's absolutely fine. So let's give you the answer to the question. So actually, brain development is not a linear process. And the kind of critical development changes that occur in these very last gestation weeks we really underappreciate that it's actually between 34 and 40 weeks of gestation. A lot of things happen. So the brain weight at 34 weeks gestation is actually only 65% of that of the full-term brain. So in the last 6 weeks of gestation, that brain is growing, the weight of the brain is growing by 35%. And also at 34 weeks, the kind of brain, the gyral and the sulcal formation, it's really incomplete. And that cortical volume, so, you know, all of this cortical activity, this increases by 50% between 34 and 40 weeks gestation. And about 25% in total of the cerebellar development occurs during this time period. And I always like to point this out to people when we have these 34, 35, 36 speakers in our care, and we just think they're a small term baby. Okay, yes, they're small, but they are not a term baby by any means in terms of their brain and their brain function. And they're still an at-risk group when we think about the infants who may have neurodevelopmental challenges. So again, in this late preterm infant, this period between 34 and 40 weeks gestation, it's critical because this relative percentage of both the grey matter and the myelinated white matter to total brain volume really increases exponentially. Okay, so again, I want to ask a question of you guys, which is, which of these factors do you think influences how the brain develops? So how do you think, what influence do you think happens? Is it just a genetically predetermined process? Is it the endogenous stimulation? Is it the exogenous stimulation? Or is it all of the above? What do you think influences how the brain develops? So let's see what people have voted for. So I'll share the results. So 96% of you guys think that all of these factors influence how the brain develops. So again, let's give you the answer. And in fact, yeah, 96% of you really are correct. Hopefully the slide's coming up. There we go. So 96% of you really are correct. There's lots of factors to how our brains develop. It is partly a genetically predetermined process. My husband always says he blames my mother and father for who I am. And the person I am because of the genetic pre-makeup that I inherit from them. But it's partly to do with endogenous stimulation. But what we must remember is that a lot of it to do is exogenous stimulation. So all of this external stimulation actually affects the firing and the wiring of the brain, and our brain is developed really based on experience. And there's work done that really shows that the impact of early experience can have effects on our brain development and particularly on our personalities and who we actually are. Now, it's not just about the physical makeup, as I said, it's also about the neurons, and there's also always the debate out there. So is it nature or is it nurture who makes us what we are? What's actually influencing our brain development and our brain pathology? So we know that, you know, continuously our neurons are migrating and reorientating, but in the first month of life, there's a huge amount going on in the brain. In the first month of life, the number of synapses will actually increase 20-fold to like 100 trillion. And there's really not enough genetic material to specify so many connections. What we know is that the impact of experiences is critical. Experiences either strengthen or weaken synapses. Experiences strengthen or weaken brain architecture. So it's important that the experiences we offer our infants in the NICU are very, very positive. And it is a lot, this impacts this neuronal migration and an organisation that's happening continuously within these infants' brains. And you can see at the bottom here, these neurons from 26 weeks compared to the infant at 38 weeks are far less organised and connected at 26 weeks as they are to 38 weeks. And if we again think about the critical phases of brain development, we can see that this migration and organisation is happening anything between 3 months post-conceptionally up to post-birth. And then again, let's put that into context with the pictures, the graphics of the brain that we actually see. And we can see, therefore, that brain development is actually most active at 24 to 40 weeks of fetal development. It's the time and the opportunity that we in neonatology can influence positively this brain development, and we can provide the right environments for these babies to actually grow and nurture in. So I want to ask you a question based on this slide. So let's see what we said. So let me ask the question of you. At which part of fetal development does neuronal organization take place? So I'm going to launch the poll and let's see. So neuronal organization, so not the migration of the neurons, but the organization and connection of these neurons. When is this actually taking place mainly? So again, I'm going to close the poll for the sake of time and share the results. And actually, if we think back to that slide we just showed, it is 6 months to post-birth when most of the organisation is actually taking place. So half of you really got that correct, so well done. So let's think about the maturation of the infant's brain, and let's put it in context again with the AEEG. So some maturational features are normal at some gestational ages, but they're abnormal if they're present at different stages. And what we do know, as we mentioned earlier, about the preterm AEEG is it becomes more continuous as the babies mature. And as the babies mature, those interburst intervals become shorter. But as well as the actual pattern and the continuity, the sleep-wake cycling matures also. And you remember we said, if those of you who joined us last week, that the sleep-wake cycle appears as this kind of sinusoidal pattern with varying bandwidth and continuity, and we see it much more discontinuous during quiet sleep than during wakefulness and active sleep. And it really is represented by the kind of the broader tracing with a lower minimum amplitude. And it is normal to see sleep-wake cycling in preterm infant, and we can actually see sleep-wake cycling very well in healthy infants from 23 weeks gestation onwards. If we don't see sleep-wake cycling in these preterm infants, then that is abnormal. So we know that getting sleep as a preterm is very important. This was a very nice study that was done by the group from Utrecht in the Netherlands, headed up by them. And they looked at these infants, they looked at their sleep state transitions. So were they transitioning smoothly between alert and quiet sleep? And they were looking at interactions also where babies may have been in a quiet sleep state, but were suddenly interrupted and woken for something, a procedure, a caregiving activity, whatever it was. So again, they looked and they said that these infants whose sleep state transitions, they were mainly characterized again by shifts between quiet sleep and wakefulness, exhibited the best development, including greater neonatal neuromaturation, less negative emotionality, better cognitive development, and better verbal, symbolic, and executive competencies at 5 years. And that was in comparison to infants who cycled mainly between very high states of arousal, lots of active sleep, cried a lot, and had very short periods between their active and quiet sleep. They showed poorer outcomes. And again, this comes back to the environments and the caregiving that we offer these infants to try to protect this quiet sleep as much as possible. And of course, with the AEEG, we can see when these infants are in a quiet sleep state, and we can hope to protect them at that point in time. Now, the other thing that is interesting is extrauterine versus intrauterine maturation. And what we see from looking at serial AEEGs of preterm babies at different gestations through their course is that the background activity, it seems to increase, and it becomes more continuous very quickly during the first days of life. And actually, the maturation of the AEEG background is described as accelerated. They mature much more quickly than infants at equivalent post-conceptional ages who are born later. So there's clearly some influence, again, possibly the exogenous stimulation that is causing this maturation of the preterm brain. Now, there are other things that can influence the AEEG in the preterm infant. So this is another poll question I want to ask everybody in the audience. What do you think can influence the AEEG in the preterm infant? Do you think it could be medications, cardiac output, carbon dioxide, hypoglycemia, infection? And you can vote for as many of these as you want to. Lots of people voting for lots of things on the screen. So yeah, I'll give you just a couple more seconds to answer that question. Very interesting. Okay. For the sake of time, again, you're going to have to be quick on these polls because we're short of time, a lot to get through. Pretty much there was long bars across everything. So 73% of you think medications, 50% cardiac output, 64% carbon dioxide, 71% said hypoglycemia, 64% said infection and sepsis. So let's go through some of these just a little bit more. And in fact, yes, that there can be very acute AEEG responses to various conditions in sick preterm infants. So it can be asphyxia, intraventricular hemorrhages, hypotension, absolutely, post-hemorrhagic ventricular dilatation, pneumothorax, hypoglycemia, medications. All of these things can lead to very acute changes in the background pattern, and I'm going to show you an example of that. So it really leads to increased discontinuity, electrical inactivity, we lose the sleep-wake cycling, and again, sometimes these infants have seizures. Excuse me. Again, there's a lot of work out there. I mean, you can go and do literature searches on all of the effects on the AEEG in preterm infants, and to try to summarize it quickly here, we know that medications can have an effect. So definitely surfactant, diazepam, morphine, all of these things, phenobarbital, can have an effect in depressing the background pattern. Artifacts, just the same as in a full-term baby, muscle activity, electrode positioning can have an effect on the AEEG. Cerebral blood flow can have an effect on the AEEG. Cardiac output, again, can have an effect on the AEEG. Carbon dioxide levels absolutely can have an effect on the AEEG. Hypoglycemia, all of these things can have an effect on the preterm AEEG. And this is an example here of an infant with a profound pulmonary hemorrhage. So here on the left, you see the a profound apnea just in the middle of this slide here, and I don't know whether my mouse will show up here, but this profound effect with this baby having a really profound apnea with pulmonary hemorrhage is absolutely affecting brain function. And then again, the same on the right-hand side here. This is the effect of giving surfactant. Again, it's having a profound effect, really dampening the cerebral function of these infants immediately after giving surfactant. So yes, we see acute changes in the AEEG background. They're very powerful, but remember again, they are non-specific markers of brain dysfunction. So we see this increased discontinuity, we see the amplitude depression, we may see seizure activity, and we lose the sleep-wake cycling. but it could be due to any one of those things we've just discussed. It could be cardiac output, it could be medications. There's many things that could be hypercarbia. It's our job to recognize that there has been a change in brain function and then to investigate what has caused that change. So what's the blood pressure? What medications have we given? Let's do a blood gas. Let's check the blood sugar. Has the baby had a bleed? All of these things we can start thinking about the minute we see this very acute change in the AEEG background. And often we can see this change in the AEEG before we see other changes in physiological parameters. So again, there's been work looked at the AEEG and mean arterial blood pressure in preterm infants. So certainly in most of the studies, what's been shown is that there is a correlation between the continuity of the AEEG and the mean arterial blood pressure. And that several studies have shown that the AEEG and the cerebral function improves when we improve the hypotension. So when we relieve the hypotension situation, the background pattern in these babies improves and normalizes if there's no other effects that are causing it. Now, when we think about scoring the AEEG in a preterm baby, there is a scoring method called Bergerav scoring. This is basically measuring brain maturation in preterm infants. So when they analysed 4 component variables, they found that the most sensitive indicators of central nervous system maturity were the presence of a cycling pattern, the continuity of the pattern, and the bandwidth of the cerebral function monitor recording. So they proposed this scoring system, and it is a valuable tool to be able to quantify changes in cerebral function monitoring more objectively, specifically in this preterm infant group. And I would highly recommend anybody who has never looked at Bergerav scoring to pull this paper and to look at this scoring system. So basically what they do is they give a score from 0 through to 5 based on continuity, cycling, the amplitude of the lower border, and the bandwidth span and amplitude of that lower border also. And dependent on the score, depends whether that is a normal background pattern for that infant at that gestation in time. So that's one reference I would highly recommend. It's published in the Journal of Pediatrics. I would highly recommend people to source and to read. There are many other studies and things done looking at reference values for AEEG activity in preterm infants. And this is a very nice study that was published by the group from Austria, from Vienna, headed up by Monika Olishar and Katrin Klebermas. So they tried to determine reference values for AEEG activity in infants of less than 30 weeks gestation. So they took a large group of clinically stable, neurologically normal preterm infants, and they studied them and they looked at the normal patterns that these babies exhibited in their AEEG. And they again found that there is a correlation between the gestational age and the relative duration of continuous AEEG activity. What they actually observed in this paper is that you often see 3 types of AEEG patterns. And this is an example taken from a baby who was 28+ weeks. And they looked at this baby's pattern and made the assumption this was normal for this 28-weeker, but within this time period, we could see there was periods where there was some birth suppression, there was some periods where it was continuous, and then there was the periods of discontinuity. So it appeared normal that babies would display different elements of the background pattern, despite the fact that the dominating background activity is generally discontinuous, certainly in the 28 weekers and above. And what this group did very nicely is they created standard values. They looked at the kind of medium percentage of time that these infants would display these kind of background patterns. So you can see from this table here that the more mature in gestation the infant becomes, the less birth suppression they have, and the more discontinuous and more continuous patterns that they have in their background patterns. So a very nice paper, again, a very highly recommended paper to read. This was a study that was done, and it really took infants all the way from the preterm group to about 3.5 months of age. And again, they showed that the amplitude of the AEEG rises with increasing postmenstrual age during these early infancy days, especially after the neonatal period. And they managed to kind of pull out some normative data on this. And basically, again, as you see, as these infants increase, then we see changes in the upper margin, and we see changes that lower margin amplitude increases up as well, and that would be normal. So it's again nice to have some reference values for those infants who are perhaps a little bit older also. So another question for the audience. This is a poll question. I want you to tell me which one of these statements you think is true. So what do you think is true? If you're less mature, then you have more discontinuous activity. Or if you're less mature, do you have more continuous activity? If you're more mature, do you have more discontinuous activity? And if you're more mature, do you have undeveloped sleep-wake cycles? What do you guys think is the true statement here? Again, a lot of people have voted. So I'm probably going to close the poll and share the results. And absolutely 76% of you think that if you are less mature, you have more discontinuous activity. So let's just clarify that statement. Absolutely. So definitely less mature means more discontinuous activity, and it means the beginning of the cyclic variations. If you're more mature, then it means you have more continuous activity with a much clearer developed sleep-wake cycling effect. So let's go on and talk about the value of AEEG. And one of the biggest values of AEEG in the preterms is the thoughts on prognosis of these infants. Now, this again was a study done by the group in Vienna in Austria. They're big researchers into the preterm group. So this was a study in which 143 preterm babies were looked at. They had an AEEG within the first 2 weeks of life, and then they measured their outcome at 3 years of age using Bailey assessment. So what they could see here, so they basically scored the AEEG according to the background pattern, according to the appearance of sleep-wake cycling, and according to the occurrence of seizure activity. And the AEEG was actually significantly associated with outcomes at 3 years. And so basically, if you had a normal AEEG, you were much more likely to have a normal outcome at 3 years. If you had existing sleep-wake cycling, you were much more likely to have a normal outcome at 3 years of age. And what they actually found was that the AEEG in the second postnatal week had a sensitivity of 83% and a specificity of 98% for later outcome. And they showed that AEEG has good predictive value for the later outcomes in these preterm infants, and it really can be used as an early prognostic tool. And if we think about what do we use today, what do we do today when we're thinking about the prognosis on these infants? Well, we probably do cranial ultrasound scanning. It's what we do on most babies. We look at the morphology, we look at the picture of the brain, but we don't think about the function. And they also compared cranial ultrasound in this study. And again, what they showed overall in terms of prognostic value, specificity of 98% and sensitivity of 61% with a PPV of 96% versus cranial ultrasound, which only demonstrated a specificity of 87% and a similar sensitivity. So what they actually showed here in this study was that AEEG was more specific than cranial ultrasound scans alone in determining the prognostic outcomes of these infants. So again, lots more studies have been done looking at the AEEG predicting the outcome in these preterm infants. This study looked at the Bergilov classification of AEEG and graded the abnormal AEEG recording within the first 72 hours of birth. And they found that if it was abnormal within the first 72 hours of birth, it was significantly associated with poorer outcomes. And that includes cerebral palsy, developmental delay, etc. in preterm infants at 18 months corrected age. And the severely abnormal AEEG recordings within 72 hours after birth, so within those first 3 days, can predict white matter damage and long-term poor outcomes in these very preterm infants. And so therefore, again, they determined that AEEG can be used as an early prognostic tool to monitor very preterm infants. Again, another study, early AEEG is a predictor of brain injury in low birth weight infants, and basically their conclusion was that early AEEG that showed moderate or severe abnormalities is associated with severe structural lesions that are then obviously detected in imaging studies, and it should be considered as an auxiliary screening tool for the detection of neonatal brain injuries in very low birth weight infants. This study looked nicely at the relationship between AEEG function and MRI structure, and I mentioned a little bit earlier about we should be looking at morphology or structure and function at the same time. So in this study, again, they supported a very clear relationship between early activity and brain growth processes. So again, they stated that AEEG monitoring in the first 72 hours of life and obviously an MRI for looking at the structure can be used to identify preterm infants who are going to be at high risk for neurodevelopmental impairment. Again, briefly go through these. These are all really saying the same thing to us. This one actually looked at feasibility in terms of AEEG also, and they claimed in their conclusion that the AEEG, it's feasible in premature infants, and when we collect that data at 1 week of life and we combine it with those early head ultrasounds, the sensitivity for detecting adverse outcomes was actually increased because we've got the morphology and the function. And again, similar sort of thing here. This study, again, looked at Bergilov scoring, and they looked at the measures of cyclicity in the AEEG in the first 6 weeks of life, and they demonstrated associations that were known to predict adverse neurodevelopmental outcomes by looking at those elements of the AEEG. So I am going to launch another poll question for you guys. So do you think AEEG can add additional value when considering prognosis in the preterm infant? Given the evidence we've just looked at, do you think, yes, it can give you additional value? No, you don't think it gives additional value, or are you still unsure? And that's fine to still be unsure. So I will close the poll. I hope our panel are watching this poll answer. So, okay, panelists, 98% of our audience do think that AEEG can add additional value when considering prognosis in the preterm infant. Nobody said no. Everybody, you're either unsure, and that's 2% of you, and that's fine, or 98% of people think it can add additional value, and that's really great news that you think that. I also think that. Okay, so I am going to move on and talk a little bit more about other conditions. So let's think about AEEG when we're thinking about the intraventricular hemorrhages. So we know with an IVH, the AEEG background absolutely becomes more discontinuous. So if you see that background pattern becoming more discontinuous in those first days of life, that may be an infant who's developing an intraventricular hemorrhage. And the degree of depression that we see on the AEEG correlates with the degree of intraventricular hemorrhage also. We mentioned earlier about white matter injury. There's a couple of studies, or more than a couple, of several studies looking at AEEG and white matter injury. And again, we know that during the first days of life, the AEEG shows an association between the development of cerebral echo densities, if we have that early amplitude depression, and the presence of seizure activity, especially if it's subclinical seizure activity. That was a paper written by, again, the group from Sweden, headed up by Professor Hellström-Vestas. The group headed up by Song et al., and they're from China. They did a study, and they took 63 preterm infants of less than 32 weeks gestational age, and they had AEEG within the first 72 hours after birth. And again, the AEEG degree showed significantly positive correlations with both white matter injury and poor neurodevelopmental prognosis. So again, they concluded in that study that abnormal AEEG of the preterm infant within 72 hours after birth may imply white matter injury and predict poor neurodevelopmental prognosis. Now, this is a case study. This is an infant with a post-hemorrhagic ventricular dilatation. So this is a 28-weeker intrauterine growth retardation, born with APGARs of 1, 7, and 8, was 846 grams. And on day 2 of life, they noted intraventricular hemorrhage, a grade 3 on the right, 3+ on the left. And on day 5 of life, they noticed the beginnings of ventricular dilatation, but they had the AEEG on this baby, and at this point in time, the AEEG was almost age appropriate. It was pretty normal for a 28-weeker. So despite the ventricular dilatation, this baby's brain function was normal. There was not affecting function, good cortical activity at this point. Now, they carried on monitoring and they carried on scanning. And at day 20 of life, and what's really interesting about this case, and I will share this with you, is they had done a cranial ultrasound scan almost at the beginning of the AEEG trace that you see here, okay? And it was actually unchanged, really. It was not too much significantly different, and the AEEG was normal. They then noticed this absolute acute change in the background pattern, and they did the usual: check the mean arterial blood pressure, check the blood gas, check for hyperglycemia, all of the other things that we know can make this acute change in the background pattern, and everything else was okay. So they did another ultrasound scan, and they found, significant change actually at this point in the ultrasound scan. And this baby actually went on 6 hours later to start having seizures. So the point about this this case really is going back to what I said earlier about morphology and function. I mean, you have to beg the question: is this the future for thinking about post-hemorrhagic ventricular dilatation? Because we can see the dilated ventricles, we can measure the dilated ventricles. It's a question maybe for the panel at the end, that is this something that we can think about as an adjunct in our management of these infants post-hemorrhagic ventricular dilatation? Because if we have a picture, the morphology like we have here on the left, but we have normal background pattern function, normal cortical function, is that the right time to intervene? Whereas if you look at the AEEG trace on the bottom, this is clearly normal. This is very depressed with lots of seizure activity. That baby absolutely needs intervention because that ventricular dilatation is absolutely having an effect. Okay, I'm going to move on then and talk about medications. I'm going to ask you a question about medication. So it's another poll question for the audience. It's to make sure that you're all still awake and you're not having your own sleep-wake cycle right now. So medications, what effect do you think methylxanthines will have on the sleep-wake cycling of a preterm infant? Do you think it'll have no effect? Do you think it will decrease cyclicity, making the sleep-wake cycling less prominent? Do you think it will increase cyclicity, making sleep-wake cycling more prominent? So again, I can see, so think about methylxanthines, think about that group of medications, think about what we aim to do with methylxanthines, and let's see what you guys all said. So I'm going to close the poll, share those results with you. So I can tell you 41% of you think that it will decrease cyclicity. So we're going to load them with caffeine and we're going to decrease cyclicity and make sleep-wake cycling less prominent. But 56% of you think that it will increase cyclicity and make sleep-wake cycling more prominent. So let's go on and take a look at the influence of medications. So with medications, we know that the AEEG background can be suppressed by lots of different medications, things like diazepam, midazolam, surfactant we mentioned earlier, phenobarbital, morphine, sufentanil. All of these things can suppress the background pattern, but in contrast, methylxanthines actually increase electrocortical activity in preterm infants, and they can make that sleep-wake cycling more prominent. It's just very important to think about every time we look at the AEEG of a preterm infant, anything else that might be influencing it. Have I given medication? Is there other morphology going on here? What is influencing that background pattern? And this is a nice example of an infant who was just the effect of 5 milligrams per kilo of phenobarbital. So it was clearly not a normal background pattern in the first place. But look here, look in the center here. This is when the phenobarbital was given. Look at the effect it's had. It's absolutely flattened that background pattern. Okay, so sedation in any form and things like phenobarbital really can have an effect on the background pattern. And this was a really nice case that was shared with me by one of our key opinion leaders in Europe, and it was looking again at the surveillance of sedation, and the top AEEG trace is different to the bottom AEEG trace. So if you look at the top trace, that was a baby who was already probably in a burst suppression plus phase, but gave medication in the center, and there was some degree of depression, and it recovered and they went back to their previous tracing. Now look at the second one. this is a baby who actually had continuous normal background activity. This baby at the beginning of his trace had continuous normal background activity, and he was given sedation, and it absolutely flattened him down for quite some period of time, well over an hour, until that trace gradually started returning to normal. And excuse me, I often use this as an example when we're thinking about giving sedative medications, that, you know, nurses are very keen to come forwards and say, this baby's very agitated, we need sedation for the baby. So very keen nurses to hold up hands and say the baby needs sedation. But I don't think as yet I've ever met a neonatal nurse who's told me I've over-sedated the baby, because nurses like sleeping babies. So it's actually quite good to be able to measure and survey the amount of sedation we've given to check that we're not actually overdoing it and really flattening these background patterns down. Now I want to move on just a little bit. We just talked about phenobarbital, so I want to ask you a couple of questions about seizures in preterm infants. So do you think it's more difficult to identify seizures in preterm infants or not? Do you think it's more challenging in the preterm infant? Do you think you're quite good at it? You don't think it's any different to the full-term infant? So again, quite a lot of results coming in. I'll close the poll. I'll share those results with everybody. So actually 86% of you think it is more difficult to identify seizures in preterm infants. And, you know, after 30 years in neonatology, I'm one of that group. I do think it's more difficult because these preterm infants have these kind of twitching kind of movements that are normal for them. They're not seizures. Okay, so that kind of then is going to lead me into my next question. We think it's more difficult to identify seizures, but we're not monitoring them continuously. Okay, so my next question to you, if you think it's more difficult to identify them, are you afraid of over-treating seizures in preterm infants? If you're performing AEEG, do you think you will over-treat these babies? Oops, let me launch that poll. Sorry, it's not launching for me. Come on. Okay, that's launched now for everybody. Oops. No, for some reason, guys, that poll, oh, hang on, maybe it is. No, sorry, guys, that poll's not working, but don't worry. It's often a question, you know, we have discussions, or if we're monitoring with the AEG, are we going to over-treat these babies in terms of their seizures? Should we treat all of the seizures in preterm babies or not? Should we only treat the clinical seizures versus the subclinical seizures? And, you know, I think the jury is still out on this a little bit, and you get different reactions and from around the world when we think about this. But this is an example. This was an AEEG, and you see in the center here where that red arrow is, this was a seizure in a 26-week gestation infant. And actually this was a subclinical seizure. This was a baby, actually had a grade 4 intraventricular hemorrhage on ultrasound, mechanically ventilated, sedated, got a continuous infusion of morphine on board actually, which is probably why that background pattern is also slightly depressed. And as you see here, this baby developed this short seizure, and it's seen in the AEEG traces, that very abrupt and transient rise in the lower margin and a spike up at the top. And you can see at the bottom also the raw EEG. So what we know about seizures on the AEEG in preterm babies, we can identify them in the same way as we can full-term infants. And we also know, and this is important, that epileptic seizure activity, often without clinical symptoms, and I mentioned this earlier, they're often subclinical, is very common in the AEEG during the development of intracerebral hemorrhages. And again, as I just mentioned, epileptic seizure activity in the preterm infant is often more difficult to assess. We rarely see status epilepticus. It's not never there, but we rarely see status epilepticus in the preterm infant. But we see these kind of seizure activities, I say, often without clinical symptoms, and often as these babies may be developing hemorrhages. This actually slide in the wrong place. It should have been with the methylxanthine, and I apologise for that. Again, this was a nice study that looked at the effects of postnatal agent aminophylline on the maturation of the AEEG. So, you know, we know we give methylxanthines routinely to avoid apnea of prematurity. So it was a small study group. It was 19 preterm infants between 23 and 30 weeks. And they had an AEEG recording done 1 hour before to 1 hour after the administration of the methylxanthines. And they saw the amplitude in the AEEG rising. So again, they concluded that methylxanthines increases cerebral cortical activity in preterm infants, and it makes the sleep-wake cycling more prominent. Okay, so I'm going to share with you a case study that was actually shared with us. And it really, again, this was really looking at trying to identify seizures in these newborns, in these preterm neonates with severe intracranial hemorrhages. So just to give you the demographics here, this was a 25-weeker. This was a baby who was actually an ex-utero transfer from an outside hospital. It was mother was gravida 1, para 0. Maternal history was significant for gestational diabetes, hypothyroidism, E. coli, Klebsiella UTIs. She had polycystic ovary syndrome and prolonged rupture of membranes. So clearly this baby has not had the best start. They didn't know her group B strep status at that point in time, but she received ampicillin, betamethasone, magsulfate prior to delivery, and they delivered this baby by a cesarean section because of breech presentation. The baby was delivered with 600 grams, female baby, floppy and apneic at birth, required intubation at APGARs of 1 and 7 at 1 minute and 5 minutes respectively, was neutropenic, had DIC. Again, the baby got ampicillin and gentamicin, FFP, cryoprecipitate, and they transferred the baby to the level 3 hospital. And what they did their cranial ultrasound on day 1 of life and day 5 of life, and there was no intraventricular hemorrhage. However, after the cranial ultrasound scan on day 5, the baby had a severe bradycardic event that was associated with hypotension. She developed metabolic acidosis and thrombocytopenia. So they repeated the head ultrasound the next day, and it demonstrated a left intraventricular hemorrhage, distending the ventricle, and they all demonstrated a right intraventricular and parenchymal hemorrhage. So they actually did some AEEG monitoring on this baby. And this is what the AEEG showed. So I want you to look very carefully at this AEEG trace, because I'm going to ask you what you think you can see here in terms of background patterns and potential seizures. So look very carefully at it, and I'm going to ask you, what do you think this shows? Does it show continuous voltage, discontinuous normal voltage? Does it show elements more of burst suppression with seizure activity? Does it show burst suppression alone or continuous low voltage? So let me launch that poll for you guys to be able to vote on. Hope this one works. No. The polling has decided out. There we go. Let's try that. So the AEEG shows. What do you think the AEEG shows? Does it show continuous normal voltage, discontinuous, burst suppression with seizure activity, burst suppression alone, or continuous low voltage? So very interesting. I'm going to, again, we're getting short on time, so I'm going to close the poll. And I'm going to tell you, you guys are good. So 50% of you thought that you saw bursts suppression with seizure activity. So let's go on and look what we found. Now, for those of you who know the Olympic Brains monitor well, you know that there is a seizure detection algorithm within the monitor. And the seizure detection algorithm marks the top of the trace here with orange markings, okay? So you can see the orange markings hopefully above the AEEG trace there. So actually the recognized seizure detection algorithm marked numerous sections of the raw EEG and the AEEG, even though there were no clinical seizures seen. These were all subclinical seizures, and they clearly consulted neurology. They did a full montage conventional EEG, and again, that conventional EEG was abnormal with left temporal positive sharp waves and repetitive sharp waves in the occipital and central regions that actually eventually evolved into electrographic seizures, again, without clinical correlate. So the discussion that came out of that case study, and this was the discussion from those clinicians, it's from the United States, they said that AEEG detection of suspected seizures is often based on the classic findings of the elevations in the upper and lower margins of the compressed AEEG trace, and that this case really highlighted two important points to them. Firstly, it represented this clinical scenario where the seizure detection software identified repeated episodes of low voltage rhythmic activity where there was really very little elevation in the upper and lower margins. You couldn't really see it on the AEEG, but it was visible in the raw EEG, and the seizure detection software actually captured that. It was very quickly identified. And it's partly because these seizures were actually very low amplitude, and the background activity was at that point before the seizures discontinuous, didn't cause an elevation in the upper and lower margins. Secondly, this case really provided confirmation that monitoring for seizures in neonates with severe intracranial hemorrhages is useful, because over 50% of the seizures are subclinical or they're really not associated with overt physical signs. And early recognition of seizure activity, it's important because the prompt treatment of seizures may reduce brain injury and improve the neurodevelopmental outcomes. So I just want to kind of finish off here by sharing with you a sample protocol of monitoring AEEG in preterm infants. So a sample protocol could look something like this, that you might want to monitor all your infants between 23 and 34 weeks gestation. You might not want to do it continuous. Maybe you're going to do serial AEEG recordings on a weekly basis, unless there is pathology that you really want to look at. We often avoid needle electrodes in the extremely preterm infants because of the underdeveloped layers of the skin. Obviously, qualified practitioners need to interpret the trace and use the information in conjunction with the cranial ultrasound scans and the MRI findings. We never use AEEG alone. It's part of our toolkit. It's something that we use as an adjunct to our clinical examinations and our scans. We do have to take care to analyse the data based on other influencing factors. So we have to think about medications or physiological parameters like a drop in mean arterial blood pressure. We should interpret the AEEG based on gestational age and the normal expectation of that background pattern, and we should report on those traces. As we mentioned last week, they must form part of the medical record and be identified with patient details. So to conclude, I think I would like to conclude by saying AEEG, it is feasible and it is useful in preterm infants. It really can give us excellent information on both short and long-term changes in brain activity. We now have the normative data in AEEG for preterm infants. It's very well described. We know that brain injury is associated with depression, with seizures, and with loss of cyclicity. We also know there are several medications that are associated with transient AEG depression. We have to bear that in mind. Again, always remember that there are physiological factors, blood pressure, carbon dioxide, glucose, etc., that can influence AEG. It's very useful for the detection of seizures, well, especially the electrographic only seizures, and it can help us in the timing of interventions, like we mentioned earlier, things like ventricular taps in the post-hemorrhagic ventricular dilatation infants. Again, if you want to learn more, there is a wealth of information that is available on the Neonatal Care Academy. There are 2 excellent courses. One from, well, she's now Professor Katrin Klebermas from Vienna on AEG in preterm infants, and another from Dr. Purva Deshpande from Canada. Superb courses on AEG preterm infant. So on that note, you guys will be glad to know that I finished. And I'm going to hand over now to our excellent panel, who are going to, Dr. Prashant, I'm going to make you the presenter.
Yeah.
There you go. You should be able to share your screen. And I thank you all for your time. I apologise I have to leave the panel discussion, but I'm very much looking forward to being with everybody next week to go through a really good case studies.
Tell her to send all the questions to me.
Yep. Thank you, Judy. Wonderful presentation, and that's why, you know, we've been getting extremely good feedback because of the wonderful presentation. Thank you very much, and we understand. Thank you very much for yeah. So from here on, our panelist will take over. Thank you, Judy. Carry on. Thanks for wonderful.
Okay, thank you, everybody. Thank you. Bye bye.
Judy, excellent talk.
Yeah.
Yeah, I think we'll move on to the discussion with our panelist. So this has been the most sought after. Last first session when we did on July 22nd, I got huge, great feedback from all the attendees. So this is going to be a mix of the theory plus the practical demonstration will happen. So we have got wonderful panelists. We have Dr. Amit Mathur from USA, Dr. Monica from Dubai, Dr. Leslie, and Dr. Sidhu from India, and Dr. Jafar Khan from India. And Dr. Dinakar sir will be monitoring, will be showing the demonstrating the machines when the panelists are explaining and telling about the each and every features. So let us start the session. Panelists, are you ready?
Yeah.
Yeah. So here we go. Is my screen visible? First slide.
Yeah.
All right. So we'll move on to the first question. This is for Dr. Monica. Ma'am, this is about significance of documentation of ambiguity. Can you tell us about the
there is some voice disturbance.
I think we will do one thing. This is for the presenter. No. One second. Yeah, Anviti, if anybody has disturbance, kindly mute yourself because only the panelist microphone is on. So
okay,
that
sure.
okay.
Everyone else in the panel can go on mute unless and until it's your turn to talk. I think that will be better.
Yeah. Can I start, Prashant?
Yeah, please start, ma'am.
So I would say to everyone, it's an amazing kind of initiation, and we heard Judy, which was excellent kind of a talk. And I think none of us could think about, using this. Most of us at the preterm also, this is a good modality. Thanks, Judy, for that. And regarding the documentation, I would say that anybody who is presenting, who is working in a NICU or any intensive care unit should have their protocols in hand for whatever they are doing, whether it is a small procedure like putting a cannula or doing a bigger thing, putting a long line or putting on a ventilator. So we have in place all the protocols, and they are very, very essential. So when because you are some of you are using going to use AEG as the first time, so you must know the way you are going to put your protocols in. So that's why it's important here. So I would start from the equipment selection, because that's the first thing you're going to do. And I would say that whatever, first of all, is available and everyone is used to it, should select such kind of an equipment which is user friendly. But at the same time, you have to see certain specifications, what you are going to be looking for when you are going to look for a kind of equipment. So the equipment should be taking 2 panels at least, and then they should be EEG and AEG both running simultaneously, because sometimes we have to go back to validate ourselves to look at the EEG as well. And then there should be an ECG, which should also, your equipment should have that facility, so that sometimes you have artifacts with the ECG and how to know until unless it's running by the side. And then the other things what you should be looking for is that there should be an algorithm of seizure detection and algorithm of background classification detection. Plus, there should be a grayscaling availability. So just look at those and then put it in your place. And then comes, once you have an equipment, you have thing, then you will, first thing what you will do is sensor application. So who will apply the sensor? Now this cannot be like, okay, this is the only job of a nurse, so I'm not the one who's responsible. That should not happen. But at the same time, because sometimes, you know what happens, which is easy thing to do, if as a doctor we are not doing, we don't know. So, you know, you should, the people who are going to do it should be have training, whosoever is going to apply, whether it is a doctor or a nurse or a technician who's going to apply, so that thing should be well written, and it should be in the privilege, that this is privilege given to them. And when they will apply, as soon as you decide that, you know, you are going to put this baby on an EEG, you will apply immediately. So whether it is an HI, it's a depressed baby who is requiring bag and mask or ventilation, or who has got a low score, Apgar score, whose pH is low, who is scissoring, if a baby who is preterm, who has got IVH, you know, or it is an inborn error of metabolism, or some meningitis who is having seizures. So whosoever, the moment you think there is a problem, just apply it same time. And which sensors will you use? So usually in our unit, we are not using the needle sensors. We are using for all the babies gel sensors, especially for a preterm. It becomes very much needed that you should use a gel sensor, because you know the skin is so fragile and thing. But if you want to use AEG for a longer period, then you should go for a needle sensor, because it will not get displaced easily. Otherwise, you know, with the gel sensors, you may have a problem of getting displayed now and then. Then assigning a role and job profile, doctors and the nurse role. So who will you monitor? So you can actually say, I would say that my nurse, who is going to be 24 hours with the baby, is the one who will be the most reliable one to monitor. And she should be trained to pick up at least very gross abnormality, so that she can immediately pay attention to it and call the doctor to look at it. And at the same time, the doctor in house should also be intermittently looking at it, and the neonatologist at least should be going and every 6 hours reviewing this what's going on. And how long will you monitor? So this will depend on the condition with which you are going to put the baby on a AEG monitoring. So as we know, supposing most common condition is your HI. So when you are putting a baby of HI and you have decided you are going to cool the baby, so you will start from then. You will cool for 72 hours, and then after the cooling, then when rewarming is happening, you will count that in, and then 24 hours more. So usually 4 or 5 days, you will definitely going to put the AEG monitor. But having said that, if the baby is even all the babies will not improve 100%. So some of the babies would be still seizuring, some of them will be totally in an encephalopathic state. Then those babies you will continue to monitor for a longer period. If we have a premature babies, then you don't need to monitor so long, and also it's not good for the baby thing. So usually you will monitor the first 72 hours, which is the main time when your IVH is going to happen. And then you can go for, depending on the baby condition, weekly monitoring for 6 hours, you can do that. And if any baby who has seizures, so definitely till the time he is not seizure free, that is the time you will be actually monitoring this baby. So who will review again? The reviewing will be basically the responsibility of a neonatologist to definitely go and review, apart from the bedside nurse who's going to do it and the registrar who's going to do it. And if she tells, like, if I'm going like, okay, I will come every 6 hours to review, but if my nurse calls me and says, no, doctor, I feel there is something wrong, then I should review it more often. Then parent education, don't forget this, and I really believe in this, because I feel litigation and complaints happen because we are not educating our parents enough, and this should hold true for each and everything what we are doing to the baby. So this can happen in the form of pamphlets, which we all usually make to describe what is going to happen, but that's not enough. One-to-one eye contact and talking to them is important. Also, you can have a videos made of yourself explaining the procedure to the parents, and this can be done in a nicer way. And then documentation. So who will document? The nurse will document, and then the doctor will document, where they will document, how often they will document. So whenever you have any abnormality, definitely you're going to document, and at end of the day, you will document the whole thing. And I will leave it to the another panelist what exactly you're going to document, because it's a talk by itself, what you have to document. Thank you.
Ma'am, so we'll move on to the next. Before moving on to the next, sir, can you show us in the machine if you can add few things, Dinakar sir?
Yeah, Prashant, we will go to the next one. Then we'll show you next one.
Okay. Yeah. So I request Amit sir, what should we document?
Go to the next slide. So I think as Dr. Monica outlined, I think it's really critical to provide daily, at least daily documentation of what is going on with the baby, so that there's some continuity. If you're not working the next day and a person following you needs to know what the longitudinal course of the baby has been, you can actually read through. It's also important for medical legal purposes. I think it's becoming more and more important that we document what we are basing our decisions on. So in this nice picture that Dr. Dinakar has actually made, he has put 7 S's over here. So a short review of the history, which clearly you need to put down is in terms of your subjective review of the patient's story. So this is a 3-day-old with hypoxic ischemic encephalopathy, or a preterm baby at a certain gestational age, and what is going on in terms of an overnight event. It's important that when you review amplitude integrated EEG or any EEG, that you review the signal quality. So S for signal. So we need to make sure our impedance is below the 10 or 20 mark ohms, so that we can reliably interpret the signal. And then the background classification, the BPC pattern classification, and it's actually here in the lower right corner. I think Dr. Dinakar will show us how to assess impedance, which is visible on this right upper corner here. On the right lower corner is the background classification. So is this a continuous normal voltage or a discontinuous normal voltage? Again, you can base that on the basis of your voltage criteria for your lower margin and your upper margin. Is this burst suppression where you have very little activity, both your upper and lower margins are below 5, and there's little variability of your lower margin? Or do you have a continuous norm or a low voltage trace where there is low level of activity, or whether it's an isoelectric or flat trace? Again, these are the predominant pattern over the last 24 hours. If you're doing this once a day documentation, I think is important. If there's any changes based off time, so if the baby was initially continuous with good cyclicity and at midnight suddenly develops a burst suppression pattern, then or seizures, then you can actually go back and time that in your documentation. And what is the stability and symmetry of the trace? Is the trace quality good? Is the signal symmetric? So on the left lower corner, you can see the two channels look very different in tracing, with very low voltage up on the top, on the left side, with the right side showing some variability with discontinuous pattern and some cyclicity. So you can actually interpret unilateral injury. So if a baby has, so there could be several causes of asymmetric traces. Are the leads not well applied? Is there a cephalhematoma on one side? Is there a subgaleal hemorrhage on one side? Or is there intracranial hemorrhage or stroke on one side? So I think asymmetric patterns will point you in a lot of different directions that you need to actually go through. Seizures are again important. I think those are the main things we document in terms of episodic events. So figuring out when seizures happen, when they start, how long they last, was any treatment given, and what was the response to treatment, I think are all important things that need to be documented. And then the last thing is sleep-wake cyclicity. And I think Judy emphasized this, and I think this is probably one of the most important signatures of a healthy brain is a cyclicity, is the ability to cycle. And you can see that in babies as early as 23, 24 weeks. The pattern looks different, but they do cycle. And I think there's a concept of spontaneous activity transients, which are inherent, almost like a rhythm in the brain that happens on a cyclical nature, and is thought to be representing connections as they're forming in a healthy brain. So I think as the brain is developing, the maturity of the sleep-wake cyclicity becomes more and more important. So documenting that in your daily chart will give you a summary saying the baby's brain has been healthy over the last 24 hours. So that's those are the 7 S's that you can summarize your documentation in. And I guess Dr. Dinakar is going to show some. Is the demo going to happen now, Prashant, or later?
Yes, sir. Now, sir. Now, sir. After every topic, we're going to do it now.
Hello.
It's muted. Yeah, unmuted. Yeah. Prashant, can you see this?
1 second, sir.
The video. Can you see the video?
Yes, sir. We can see. I'll just stop the presentation so that it's easy for you to.
No. I want that presentation. I want that presentation. Whatever that 7 S's are there.
Mm-hmm. Yes, sir. Yes,
Prashant,
sir.
you can
I want the presentation, Prashant.
Then it will be
Yes, ma'am.
clearer. Yeah.
Sorry?
You can remove us. You can remove us, and only Dinakar, then they can see that more clearly, I feel, because it's in one corner. People won't be able to see what is showing.
Yes, so everyone can switch their webcams off for now, except Dr. Dinakar. Prashant, you can switch your screen on.
Is this fine now?
Yeah. See, you people can see here. So I'm going to see this one. Oh, come near. Okay. Can you people see the red one near the head? Everything. Red one. Yes, yes, yes. Can you see the red one now? All the four leads we have not connected. All the four leads we have not connected. That is the reason all the four leads it is showing red. That means now can you see it is becoming blue? I mean green. Green. It has become green. At the same time, can you people see here? It has come green. This one has come as an green. That means an impedance. See, almost the impedance line is near 0. If it is 0, that means number one, first thing 7S, what sir has told is very clear. Please, my dear friends, always when you are documenting, please tell your fellows if you are using the AEEG machine in your unit, or if you are going to take also, please tell your always try to use 7S. Number first is what sir told is take the history. Number one. Prashant, can you show the slides also? When I am telling, let them also see. Okay. Number second thing is, after taking the short history, because at least they should know whether it is a preterm baby, whether it is a term baby, what could be the history, what happens. Definitely they will be knowing in the theory. So they have to take the history. The second thing is, that is impedance. That I am showing you right now, that impedance is coming. Almost it is green now. Yeah, that means that is signal. The another one is beautifully yesterday we have discussed, and it's going to be spoken by, I think so, somebody else here. What is the CNV? CNV means continuous normal voltage, discontinuous normal voltage, burst suppression pattern, continuous low voltage, flat trace. Yesterday what we discussed, they're going to discuss in short today. Okay, number one, after all those things, once again, whether we applied the leads properly, stability is there in the leads or not. That is there. So 3S is over. Come to the other one. What is that other one? Seizure is there or not? So that yesterday we discussed how to detect the seizure. Only thing is, just like a namaskara, means like this. Always seizure will be like this. Please, I am showing you people. Seizure will be like this. Suppose if it is like this. Suppose if it is arc. Yeah, beautiful. Thank you. If it is an arc like this, arc means it will be like this. If it is like this, going and like this. If it is an arch like this, arch, that means it is an artifact. Suppose if it is an like this, strike. It is like a namaskara, like peak wave. If it is like that, what happens? It is a seizure. Then come to the symmetric. Yesterday we read why it is symmetry is very, very important. Symmetry is very important for two reasons. Whether you place the probes, whether it is attaching and short circuit is there, whether it is very far away, one is detached. Symmetry is very important. Then SWC. SWC means sleep waking cycle is beautiful. Everything today we are going to see it. What is meaning of sleep waking cycle? What is continuous? What is discontinuous flat trace? It is in this machine, CFM OBM machine, and why I am telling is this machine is better than the other. Why means number one, 5 channel is there. Number second is artificial intelligence is incorporated. What previously we used to struggle, that I will also show you in the next class. Sir, thank you, Amit sir. You told 5S. So I told the people also, what is that 5S? In the protocol, what they should follow. Number one is first history, stable or exact history. Another one is application. Another one is symmetry. Another one is seizure. Another one is what is it? SWC, sleep waking cycle. Thank you, sir. Over to Prashant.
Thank you, sir. Thank you. Thank you. Yeah, we'll move on to the next question. This is for Dr. Jafar. Who and where will you document and how often? Review, interpretation, and significance of essential marking. Over to you, Dr. Jafar. One second. Dr. Jaffer. Unmuted.
Able to attach. Hello.
You can
Yeah,
start from
attach.
beginning.
Hello. She should be able to attach all the leads properly, and she should be able to document actually normal trace as well as any abnormal trace as per the gestational age or as per the history. Okay, so first we have to she should be able to take the history, what is the baby history, and then she should be able to document. So what to document already Dr. Amit sir told that 7S, that seizure pattern or that background pattern. Now coming to the where to we can note so that it can be we can use in future. So there are three devices we can one we can note in device is already having some screenshot. So any abnormal things if she showed it, she should note. She can take a screenshot over the machine only. That screenshot can be taken as a storage, and then we can give it to patient and in USB or in any other document, and that printout can be taken, and that can be saved, and that can be handed over to parents for any medical legal issues. Okay, and next whatever changes in the tracings that can be noted on machine as well as in any electronic monitoring system, or that can be noted in our case sheet. So whatever tracings are coming to the monitor, she should be able to note that every tracings, if we are using both right and left, so they have to able to note that minimum voltage as well as maximum voltage. And if they are using that cross cortical, then they have to note in upper as well as lower margin of the that voltage. Even that machine also having the markers, so whatever procedure they are doing, suppose they are feeding or they are tapping the baby or some procedure, so any change in the tracing they have to put the markers. Once they are putting the markers, at least when we are reviewing the tracings, so we can know that this change in the tracing is because of some external activity. Some medication that is given to the baby, like some sedatives or anticonvulsant that is given to the baby, so that can be noted under the marker. So there is a in right circle you can see the marker, so they have to just add the markers. There are already some list of markers is there, like seizures, activity, convulsion, medication, some like feeding, ventilation, high frequency. So already there are the list of markers that can be added when whatever we are doing. Even if we want to create new markers there, then we can create new markers and we can add on that also. So whatever change in tracing after that intervention, we can see on the machine. Okay, so this is important to add the marker whenever there are change in the tracing or baby's movement. Suppose baby who is crying, so we have to note that the baby is having excessive movement or crying. So with these markers, one can review, one can sort out where these are the artifacts, or these are the true seizures or some change in the activity. Suppose some medication is given like sedation or anti-epileptic drugs, there is sudden change in the voltage from discontinuous or normal continuous to low voltage. So we have to differentiate this low voltage pattern is because of medication or due to some pathology. Okay, even we can next slide. Okay, so yeah, so in this slide you can see that initially there are pattern which is showing discontinuous pattern. After giving medication some midazolam, there is a drop in the voltage, so we have to put a mark once medication is given. So once medication is given, we have to put the mark at that same place, so one can see later on that the medicine is given at this point and there is a drop in the voltage after this. So this will differentiate between our intervention and some pathology. Next. Yeah, even if we are giving some medication like the same thing, use automation for daily notes like 7 steps what Mr. told, like cyclicity, that pattern, and seizure activity. So this should be included or noted in either in our case sheet, or we have to take snapshot, or we have to aid in some electronic monitoring system. So these 7 steps should be noted I think in every shift, or whenever there are some changes in the tracings. Next slides. Okay, so if we are using some electronic device for note, so we have to select the machine whether we are using the EEG monitoring. So we have to select yes. Then which monitor we are using. So if we are having drop down menu of different machines, suppose we can see here the Netus or Nicolette. So we have to choose the machine where what machine we are using, and then from that what is the impedance of that left leads and right leads. So whatever impedance coming, that should be noted in electronic monitoring system. Next. Okay, so once we are using on any electronic device, so we have to see that these are the right and left if we are using different the channels. So right upper margin, right lower margin, we have to note separately. Left upper margin, left lower margin, whatever the upper voltage, lower voltage, we have to note. And if we are using cross cerebral, so then for cross cerebral, upper and lower margin should be noted like this. What is the lower margin, what is the microvolt, like 5 to 10 or 10 to 25 or more than 25. And then whether there is a sleep wake cycle, whether it is mature, absent, or immature, this should be noted. Here you can see beautifully, this is the continuous voltage, where you can see that the pattern between 10 to 25, and there is a sleep wave cycle. Yeah, so here you can see that in between there is a sleep wake cycle where the wave is broadened.
Dr. Prashant, can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Yeah, excellent, Jaffer. Excellent. Just I want to take only 2 minutes of your time, please. Can you go back the slides, Prashant? Because live demo I'll give. Anvati, can you only make our slide? So our video.
Is it fine now,
Yes.
sir?
No, I want to see only video.
Yes,
It
sir.
should be bigger.
Yeah.
It should be in the center.
That they have to adjust, sir,
thank
whoever
you.
is holding the camera.
Done, sir. Can you
Yeah,
see it
don't
now?
shake.
Okay, thank you. Don't feel bad, yaar. He's young, but he's standing. Please, please. Okay. Okay. See, first one, beautifully sir has told, who should document? Number one, either doctor or nurse will document in the progress sheet. Nurse will do it in the nurse's notes. What she should do, documentation. Two things, whether seizure is there or not. If anybody is using the older machines of AEG, they should, doctor will tell where is the seizure. Otherwise, doctor would have taught the nurse this is the type of seizure. If it is documented, write the time seizure has come. Otherwise, if she is doing or giving any injection or anything, doctor would have advised, I am touching the baby for the changing of the pamper, I am cuddling the baby, I am giving milk, or I have put on HFOV, I have put on something else, I have put on something else. So number one, all those things previous machines was there. I mean, there was no artificial intelligence was not there. So it was very difficult. But now, in the newer machines, to avoid whether it is a convulsions, whether it is an artifact, these newer machines are giving the option like this. Can you go to this thing, patient and marker?
So the marker facility is here. You just have to select which particular.
Okay, see now, can you people see here my finger? I have put a red line. That means probably system might have seen some problem where lower margin is rising or lower margin is coming very down. That's what previous times they used to see. Now, after pressing here, she has to do the marker. See, can you people see? Please, can you come near, sir?
Hello.
Here, I'm just telling you whether sister is noted seizure, whether it is sister is turning the baby or changing the pamper, or because of convulsion she is giving the medicine, or baby is they're taking the x-ray or ultrasound, or somebody is doing the examination, somebody is doing the procedure, or they're putting some electrodes. Everything, suppose somebody is doing something extra other than what it is mentioned, they can add it. See here, the technician is showing anything. Suppose pamper change. Okay, pamper change. Just and go to add. See here, pamper change word has come near the line. That means suppose if there is an elevation here, you should not think, oh, baby might have had developed a convulsions. So that is because everything, each and everything, if you teach the nurse, if that nurse is really dedicated and intelligent, definitely it will be very helpful for you. This is number one advantage of newer machines of AEG, because it is everything it is telling. Number one. Number second, sir was telling, Jafar was telling, very good, sir, it is everything entered. How can I give the document to the patients? Because I have to document. I have written, our sister has written double things. So I will go to the snapshots, go to the reports. Can you go to the reports, sir? See, this is reports. Once you go to the report, that whatever the window it was showing, it will come like in this. Can you come down slowly? Yeah. See, what is the pathology here? What is the pathology here? And just to come down, and time, and what was the impedance, and what was the AEG, EEG, and everything, what time we have done. It is there. Can you go back? Yeah. See here. See here, snapshot is there. Yeah, you have taken a snapshot. Then you are going to put the pen drive. Okay, this is the pen drive. Okay, you are going to put the pen drive backside. Show the pen drive where you are putting.
Yes.
No. This is the pen drive. So she is going to put in the backside. Immediately you can take the print out from your desktop or whatever the printer you have, and you can go. So one short snapshot you have given. Like that, sir, every 3 hours, how many printouts I should give, somebody might ask. Number one, very clever here. Go to the patient once again and go to the snapshots. See, can you people see this, please? Whatever time we have done the snapshots, because each window is 3 hours. Means each 3 hours, sister can take the snapshot and keep it for the doctor for reviewing. This is beautiful. Yeah, show them. See, it has come like this. Come down. Slowly, slowly, slowly. Okay, come down. Yeah. Here, what is the pathology it is showing? What happened it is showing? And all those things, in case if the parents need it or medical legally it needs it, we can keep it, take the snapshot or save it is in your computer, whichever the hospital computer server with a coded number, if it is necessary, because this machine is having 1 TB storage place. So you can store more than 500 or more than 1000 snapshot, sorry, 1000 patients details. You can download in this 1 TB memory is there. This is one. Okay, sir, you told me I am sister is writing, doctor is writing. And you told me machine is also documenting, taking snapshot, everything is, suppose I don't want, I want complete. That is also recorded in the machine. Go to the patient and record it, all the things into your pen drive. And wherever you need it, you take a snapshot. That option is also there. And even parent education, Dr. Monica was telling very nicely. Beautifully, she was explaining parent education. In one hospital, what they are doing, they have printed out what you mean by convulsions, what you mean by burst suppression, what you mean by low voltage, flat tracing or continuous low voltage. And what will happen in their language, they have written. So they have printed it in a very good paper. It's a nice classy paper. The print is very good, visible. I think so, provided by NCA and the Genwork. So what they are doing, they are giving to the parents, see, we have put your baby on AEG machine. So this, in case if something is happening like this, you are reading in your language, this will happen. We will show you if this is happen, whether good prognosis, bad prognosis, or how long we can continue, whether you want to continue or not, because this is a evidence. They are doing it, but they are always encouraging. Good prognosis can occur, sometimes even the machine is showing bad, like disclaimer. So parents decision is the last. This is only a picturized thing. They have mentioned it beautifully. It is working out for them. Parents themselves, they are coming, sir, okay, you have showed me this, sir, it is come like this, sir, we will watch next day. Slowly within 2 to 3 days or within 6 hours or 24 hours, when it is coming to the discontinue pattern, doctor is explaining, they are seeing their literature, what doctor has given. Okay, my baby is improving. So they are encouraging the doctor. Okay, sir, this machine what you have put, we don't mind to pay the money. It is telling us. Not only in the, what is it, even mother might have studied 10th standard, 8th standard, 7th standard, or she might be double, triple graduate. It will help you. Documentation and education, this machine will show you very good. Thank you. Over to next. Prashant?
Yes, sir. Yes, sir. Can you see my screen? Yeah. The next question is for Dr. Sidhu. The features of an abnormal EEG, amplitude EEG, and quick review. Dr. Sidhu?
Yeah, Prashant, yeah, I'm here. Yeah, basically, we can divide features of an abnormal EEG into 3 subheadings. Where we can notice is one is intermittent uprising, and if there is any evidence of loss of sleep-awake cycle, commonly seen, and there is a loss of continuous activity. What do I mean by intermittent uprising? Most commonly, it is the artifacts that result in intermittent uprising. As we have earlier discussed, the documentation of such events is important because it's an abnormal EEG. It can be secondary to our handling the child, like diaper change, feeding, tube change for that matter. Secondary to drugs or medications such as methylxanthine, where we have seen there is a prominence of intermittent uprising. And secondary to seizures. How do we differentiate seizures and artifacts? As rightly pointed by Dinkar sir, I would point it as Dinkar sign. If there is a Namaskar sign, we can say it is a seizure. or if there is an arch, then more commonly it can be secondary to your artifact. Coming to the loss of sleep awake cycle, more commonly such pattern we seen in we come across in preterm neonates, beautifully explained by Dr. Judy, and it can be seen in stage 2 or stage 3 hypoxia, where there is a loss of sleep awake cycle, or brain injury in terms of intraventricular hemorrhage or periventricular leukomalacia for that matter. We can see loss of sleep awake cycle in neonatal abstinence syndrome. I think Dr. Leslie sir will be discussing about it, so that I will leave it to sir. And one more pattern is loss of continuous activity. As we had a question poll on this, lesser the prematurity, basically we have loss of continuous activity, less premature, less continuous activity. And again, it attributes to our brain pathology, where we see white matter changes or any cortical changes, the continuous electrical activity will be reduced. And medications such as morphine, fentanyl, phenytoin, phenobarbital, this all of these contributes to loss of continuous activity. Next slide, Prashant. In this slide, next slide, Prashant. Yeah. In this, we can see a lot of artifacts of intermittent uprising, where if we can see we have to differentiate with the pointers. We can see there is a pointer in the red color which says a procedure was done. I think Dr. Dinkar sir will show it again. Next slide, Prashant. Yeah, this we tend to confuse it with status epilepticus, moreover, but this can be secondary to a false amplitude, false pro-placement, or frequent handling of a unit as such, where we need to be very particular about the seizure activity as such. Over to you, Prashant.
Yeah. Dr. Dinakar, sir?
Yeah, yesterday I think so Dr. Monica has explained in detail what is CNV. So what is DC, I mean DNV, everything. I think so everybody knows here, whoever attended, because it is a very basic pattern classification, 5 classifications. It is very good. Everybody should know. I think so I think so whoever attended today, they knows it. Okay, next we will go to the next.
So next is for Dr. Jafar Khan. Sir, why we should use amplitude EEG machine?
Super ಬರ್ತಾ ಇದೆ. ಇಟ್ಬಿಡಿ.
Dr. Jafar Khan, I think your audio is mute. One second, we'll unmute.
Yeah.
Yes, sir. Yes, sir. Over to you, sir.
Yeah.
Yeah, we can hear you now.
We use AEG machine to monitor the baby's brain whenever there is an indication, as we have already discussed, like baby who is having hypoxic ischemic encephalopathy, or babies who is having neurometabolic encephalopathy, or having some other insult, or baby who is premature, going to or at risk of some other complication. So usually we do continuous EEG monitoring for the baby who is neurologically compromised, and we also evaluate our treatment. Suppose baby who comes with the convulsions, and if we have started with some anticonvulsant therapy, so what we found that initially baby who comes with convulsion is having clinical seizures. So easily we can detect the clinical seizures when baby comes to us at presentation. But once we have given some medication, like suppose we have given some midazolam or phenobarbital, or like levetiracetam, so later on the seizures activity subsided, that clinical seizure subsided. So now we want to know whether this clinical seizure associated with electrical activity or not, because our main aim is to treat the electrical seizure activity also. So what we have found that the subsequent seizures which are coming after anti-epileptic drugs are often subclinical. So this subclinical seizure can be detected only with EEG monitoring or AEG monitoring. That's why all children, all infants which are at the risk of convulsion should be monitored electronically by EEG machine. So what we found that at around 58% of the seizure persistent after any treatment are having uncoupling of electrical and clinical seizures. So this AEG is having important role to detection of these subclinical seizures when baby or some medication. So this our goal is to treat all these seizures, so to prevent the brain injury also. So this is the most important, to detect the undetected seizures by electronically. Yeah.
Yes, sir. Dinakar, sir.
Thank you, Dr. Jafar. Very neat. I request only one thing. Many people are thinking AEEG machine is for only HIE. It is not so. Please, my dear friends, it is not only. See one thing, and somebody was asking me, Dr. Dinakar, when hypothermia we are doing, anyhow we know that up to 2 days or 3 days, seizure will come. Later it will burn out. Why I need AEG? Why should I spend money? It is only for AEG for term baby. Then I looked at him. He's a senior man. Then he is working, but he's having very tremendous knowledge because he's senior. Experience counts more than the present knowledge. Then I was talking, sir, can I talk with you a minute? Then he told, please go ahead. Then that also evening we were sitting, you understand people, dear friends. Then I told him AEG can be used not only HIE, yes. You asked me, we have started hypothermia, we are having only hypothermia machine, we don't want to buy this. Then I was telling them, sir, AEG will tell you. There are so many, I think so questions will come for the Monica and the Amit Mathur. They might answer this. Then I answered him, sir, it is very much necessary, not only in HIE. Why in HIE? I think so people will tell you, because you people only last time they've asked. Then I think so my panel people will tell you. Then I was telling, sir, preterm, अरे यार क्या बोलता है? What you are going to tell, dear? Preterm में how I can use it? Then today, after listening to Judy lecture, people might have understood. Then I told, sir, we can diagnose CO2 whether it is low or not. Suppose if you don't have what is that transcutaneous CO2? If it is going more than 60, what happens? At least you will come to know. If it is coming down less than 25, at least you will come to know. Indirectly, you will come to know, because you are not going to do that. So, and I was telling many things. Then at last he has agreed, मेरे को सबूत दिखा दो, means show me the proof. Then and there only I downloaded article and I read. अरे इतना पढ़ने, I don't have time to read all those things. Then I was telling, because he's a running successful man, he's having 20 bedded NACU, beautiful and very gentleman and thorough, and he will always accept the things. The next day, I took all the things, I underlined the things. I took from the 5-star hotel, we took all the Xerox copies. They have done it with a courtesy. Then all the things I have underlined and I gave him. Then next day, you believe it or not, within this 1 week, then can you just come and teach us? Then yes, I told. People have given this machine and he has taken, and we are in touch. He is very happy. And he is telling it is giving us. That's what I was telling. He is the one. He is having and showing in his own language, I mean state language. He is very happy about this machine. So I want to tell you, AEEG machine not only for HIE, it is for preterm babies too with multiple disorders. Next class, probably Judy and all our panelists will take in a detailed manner how in each disease you even some people who are not using might not even dreamt of it. It's really good machine. Next, over to you, Prashant.
Thank you, sir. Thank you, sir. The next thing is for Dr. Leslie Lewis, sir. What is the difference between preterm and term amplitude EEG? Leslie, sir?
Yeah. First of all, I must thank Dr. Dinakar for opening up this new arena of using amplitude integrated EEG, not only for the HIE babies, but also for our preterm babies and other babies. And he has done, with the help of NNFK, a wonderful job. Dr. Judy has already explained in a very crisp way for the last 1 hour using a amplitude integrated EEG in a preterm babies. She has also showed a same picture. I just want to recap on what she has mentioned. I want all our participants to concentrate on this beautiful the picture, and few things as she has repeatedly mentioned. When we are recording or reading a EEG, remember, first thing, describe the background pattern. And here, if you see, first column says what is the background pattern. A second thing she mentioned, describe the cyclicity or a sleep-wake pattern. And that is there in this picture. And then maybe we have an amplitude, minimum amplitude and maximum amplitude, which may not be much of an importance. Let us concentrate only on this first two columns, the background pattern. And she has mentioned repeatedly, the more premature baby, the background pattern is discontinuous. And as the baby matures from a prematurity to a maturity, this discontinuous pattern is become a more of a continuous pattern. And then as the baby matures further, we are able to develop a discontinuous pattern, discontinuous pattern in a quiet sleep. So the message of very clear, more premature baby, first is it is very discontinuous pattern. The baby matures, it is a continuous pattern added to a pattern of a discontinuity in a quiet sleep. Now let's look into the second column beautifully, the sleep-wake cycle or pattern. The more premature baby, there may not be a cycle or sleep-wake cycle or cyclicity developing. But if you see a few of the EEG tracings, just appearance of this sleep-wake cycle or cyclicity is there. As the baby matures, a baby will have a more sleep-wake pattern and the cyclicity is there. So these two important things we must remember when we read a EEG. One is the background pattern, is a more discontinuous in a more preterm baby, becoming continuous as the baby matures, and the sleep-wake pattern is become a more regular as the baby matures. If you look into the amplitude also, the minimum amplitude in a premature baby is a less, but as the baby matures, a slight increase in the microvolt voltage capacity of this minimum amplitude is there. If you look into the maximum amplitude, we will show the few pattern here. The maximum amplitude is very high in a premature baby, but as we come to the maturity, in addition to a continuous pattern, in addition to a more of a sleep-wake pattern in a regular interval, the amplitude comes down. And this is a crux of a differentiating a preterm baby's EEG versus the EEG of a term baby. So again, I'm repeating, preterm infant, the dominating pattern is discontinuous future. There may be periods of high voltage, and this is you can see the background pattern here in a very preterm baby, which is a discontinuous, and you can see some of the sleep-wake cycle is just appearing, but they are not regular. And if you see the amplitude of this or the voltage is higher. As the baby matures, you can see this the voltage is becoming a lesser and lesser. And she has mentioned very beautifully something called as a Barlow scoring, where the continuity, background continuity, a cycling pattern, the amplitude of the lower border, the bandwidth. I can see here the bandwidth and the amplitude of the lower border. And what she says, this amplitude of the bandwidth comes down as the baby matures. So this is what we are seeing as the baby more matures. The voltage comes down. We see a continuous pattern. We see a sleep-wake pattern. And this is a classically we have seen in a 34 to a 36 weeks of gestation. And this is the discontinuous background is there. And there are quiet sleeps are there in between the quiet sleeps, and these other background activities are there. So she has also mentioned 3 patterns there. One is the burst suppression. They are very predominant in a preterm baby, and then burst suppression changes to a discontinuous, and subsequently we can see here some of this burst suppression and then becomes a discontinuous pattern, and then a more becoming as the baby maturing becoming continuous pattern. The burst suppression pattern is very high in the 23 to a 25 weeks baby, and then appearance of the discontinuous pattern. The burst suppression here comes down significantly, and then the discontinuous pattern are becoming more, and then here there is hardly a burst suppressions, or very few burst suppressions are there. The discontinuous becoming a lesser and more becoming a continuous pattern, and classical a sleep wake pattern it is developing. Next slide. So summing up, please remember a preterm baby, it is a discontinuous or no cyclicity, or just appearance of the sleep wave pattern. And as the baby more matures, the sleep wave, this discontinuous pattern become continuous, and we have a regular sleep wake pattern will be there.
Thank you, sir.
Dr. Leslie, it is really good, really good. Just I'll take only 30 seconds, that's all. I don't want to go very deep, because today class is premature. How to use this machine? I will take only 1 minute with your permission. Leslie, can I?
Yes, yes, you have to go. Okay. You have to go.
Okay, can you go to the previous slide, Dr. Prashant? Previous slide. That previous slide. Previous slide, Prashant. That previous slide. Prashant, one graph will come. Graph will come. Graph.
First slide. Before that. Yeah, that is
yeah, Prashant. Dear friends, here only one thing you please observe. Whoever watching, only one thing you observe. If anybody is interested, please observe this. It is beautiful, because 24 weeker they have started. 24 weeker to 38 plus weeker means it's a full term wave. See, go to the minimum amplitude. What is happened? From 2, it is slowly increased to 7. Means more than 5. Increased as the gestational age increased. Go to the maximum. Thank you. From maximum, it started coming down. That means the neuronal synapses is started coming together. Extra impulses, it is coming as an volts. I mean, what is it? Microvolts. It is started reducing because it is brain is started organizing. So one thing you understood, minimum is increased, means basic electrical activity is increased. The maximum burst, it is started coming down because it is organized. One thing you understood now as it is matured. Suppose there is a pathology. What happens? Upper one is rises. Lower one is also rises. In example, seizures. Suppose there is some minimal pathology. where upper one is only rise, lower one is like discontinuous or continuous low voltage. This one you remember, but very important, see the bursts. What is everything is more than 100. I think so. My other speaker is going to talk about this. Sir, Prashant, so you understood with this slide, this much you understand. Next slide, Prashant. Prashant, next slide. Next slide. Sir, 1 second, hold on. See here, less mature, sir has told beauty. Okay, good. See, as 24 weaker A, B is 30 weaker, sorry, 28 weaker, C is 30 weaker, and the down one is almost 35 weaker and 38 weaker. It is coming near. What you mean by continuity, you should understand. That means lower margin is above 5. Number one, lower margin is above 5. And one more thing is lower margin and upper margin, always it is the dense pattern is maintained. It is not like IBI, interbus interval, it is not there. So continuity is there. That is one. Next, go to that. Remember one more thing, discontinued pattern for a preterm baby is normal. You should not think abnormal. Next. Okay, this is also next. Prashant, next. Sir, this is the one I want to tell you. Please, my dear friends, suppose 30 weaker baby, see 25 weaker, everything is below 5, almost touching 2. 30 weaker, the upper limit is going high and it is also lower border is rising. Go to 35 weaker, it is almost touching 5. So 30 weaker is almost lower border is when it is 4, like 25 weaker should not happen. Means lower border should not come. And burst suppression should reduce compared to the, see, in 25 weaker burst suppressions is more. Means discontinuity pattern is more, sleep wake cycle is not there. If 30 weaker, it's a preterm man, it will appear. If somebody is telling, you should always have a one comparison normal healthy 25 weaker chart. Even myself, what I did is I have copied the normal charts, I have kept it for my references. What is the normal for 25 weaker, 26 weaker, healthy normal 25 weaker, 26 weaker. So I'll compare them. There is no harm in comparing. So if it is 30 weaker, should not have 26 weaker things. So then it is abnormal. Remember, that is the one thing I want to highlight here. Go to the next slide, sir. Next question, sir.
Thank you, sir. The next question is for Dr. Monica. How amplitude EEG can predict outcome in HIE?
Yeah, okay. So this is what Dinakar was telling. This is not the only thing we are looking EEG for, but this is one of the most important thing I feel. So we should be talking about it because once we are seeing any kind of baby, and especially this asphyxia, then we need to know and we need to know ourselves as well as tell the parents what is going to be the outcome and prognosis for this kind of baby. So that's a very important thing. And I would say this AEG is like one of the tool when you are assessing a baby neurologically. So actually, if we will go back to the era when we were, we can't talk about this now because the research has well proven that we will be doing hypothermia only for any baby who is asphyxiated and coming into the category of asphyxia, requiring the, but you know, before that, when the studies were going on, looking at hypothermia versus no hypothermia. So from there, we could gather the information that if we, if the baby is in the normal temperature, then the normal EEG pattern would return back early on, between 24, maximum 36 hours. But if the baby is cooled, then because of the cooling itself, the cooling is a state where, you know, it will suppress the EEG pattern. So not that only baby is not okay, but cooling itself has that effect on. And also If it is school baby, then if you don't see normal pattern at 36 hours, don't say the baby is abnormal. We can wait for 48 hours and maximum 60 hours when the baby can return back to normal, and then we can say the baby is fine. This is one thing which everyone should always remember, and I will emphasize more with that study, because that's a beautiful study which was published in pediatrics. So you can see that time to normal trace, out of all the factors, can you go back, Prashant, the previous slide? Yeah. So the things which we need to see for prognosis is the background pattern. So the background pattern, what we have to see, whether discontinuity is increased or whether the low flat trace is there, loss of sleep-wake cycling is there, seizure activity is coming, or it never achieved a sleep-wake cycle, and time to normal trace, that is the best predictor, then the time to normal sleep-wake cycle appearance. So now from where these all evidences came, that I will tell you. Next slide. So this was a beautiful study which was published in Pediatrics in 2014. And what did it show? So in the x-axis is the outcome of, so because they were doing a study, so it was normothermia and hypothermia. So they could actually compare the two groups. And in the, you can see this is a normothermia with good outcome, normothermia with poor outcome, which could be disability or death. And this is hypothermia with good outcome and hypothermia with poor outcome, which could be disability and death. And there are different markers which will depict that. And on this axis, you can see that this is the time when the continuous normal pattern came into place. So this is the age, like 12 hours, 24 hours, 36 hours, 48 hours. So when the time to normal trace has come. So if you see that if the baby is normothermic, the time when the trace would come to normal is less than 24 hours. Mostly are coming within 12 hours. So maximum you will take as 24 hours. However, if it is taking longer than this, in the normothermic patient, like if you see this is 36 hours and this is 84 hours and this has never regained, it is going to be a poor outcome. But what's happening in the hypothermia group? In the hypothermia group, even with a good outcome, it is the babies are coming back to the normal tracing even at 48 hours. There was another study which showed 36 hours, but this study showed 48 hours. So we will take it as 48 hours because we want to be more sure before we tell the parents that your baby is going to be in a bad prognosis. Poor outcome babies in the hypothermia group is taking a much longer time, more than 48 hours. And they are mostly never coming back to the normal. So they are either having disability. Most of them which are coming late after 48 hours are disabled, but those which never came to normal are either dead or severely disabled. So this is a very important slide. The next is, next slide. Okay, so then is the sleep-wake cycling. So when is the baby coming back to a sleep-wake cycle? So the time to come to that is, again, it's taking more longer time for baby to come to sleep-wake cycle. And especially if you see when their baby is cooled, the auto-regulation of the sleep gets more affected. So it will take time, much more time for sleep-wake cycle to return. So in the normothermia group, the babies who are fine, the sleep-wake cycle returns quite late, even 60 hours it might take. And those who are disabled will take much more time, more than 60 hours. So 72 hours cutoff we will take for the sleep-wake cycle in a normothermia, 48 to 72 hours. In the hypothermia group, it takes more than 72 hours for babies to come back to the sleep-wake pattern. And only when it is going beyond 72 hours or whenever it is returning, then the babies are not okay. But otherwise, these babies would be okay. So if you don't get a sleep-wake cycle within, even at 72 hours, don't get upset. These babies may be fine. However, if the sleep-wake cycle is taking more time or never returning, those are the babies in hypothermia group which are going to be disabled or they may die. So this is important. And next slide. So when you compare between, so x-axis is time to sleep-wake cycling and y-axis is time to normal pattern, continuous normal pattern or continuous normal pattern for that particular age. So we will see that when both are okay, like time to sleep-wake cycle is less and time to coming to the normal is less, then the babies are going to be normal more. As the sleep-wake cycle is going to take longer time and also the time to coming back to normal is taking longer time here, those are the babies which are going to be worse. So when we combine both of them and if both are delayed, then that definitely you will tell the parents, oh, this is baby is going to be having a bad prognosis. So this is what we can find from this slide. I hope it is clear. You can see. So when we use on the whole, as I told you earlier, that it is sometimes better than the even neurophysiological imaging, MRI, it is sometimes better than even clinical assessment when you combine this HIE to determine the neurodevelopmental outcome. And if at birth within 6 hours you have normal background, or if it was abnormal and it came back to normal within 6 hours, definitely it's a very, very good situation where you can definitely tell your baby is going to be very good. However, if it is persisting beyond, as I said, birth suppression pattern or a flat one is persisting beyond 36-48 hours, it is going to be a bad neurodevelopmental outcome. Next slide. So now, one thing which, as I told you, from those studies, that the time to normal pattern is more important than the time to coming to a sleep-wake cycling. And if you have both, then it is definitely going to be worse. And these could be used as a biomarker of injury severity and a biomarker of a recovery, that it has come early or late. Next slide. Now, whether we can say this with conviction. So there is a very good meta-analysis which was done, and it included 8 studies where the primary outcome was abnormal neurological examination as performance by the pediatric neurologist. And the outcome measure was CP as defined by Hegberg Developmental Quotient Score less than 85 on Griffith Developmental Scale. And what they found, that this amplitude EEG is really great with a sensitivity of 91% and CI is 87 to 95. And it has got a good negative likelihood ratio. Next slide, please. So what does this meta-analysis tell us? That AEG should be part of an initial evaluation of full-term infant, whosoever we are suspecting a HIE, and it should be like a bedside tool. Now we are talking about ultrasound as a bedside tool. It is used, we are telling it ultrasound as a stethoscope. And as a sixth thing, I would say that if you have these kind of baby, this should be also equally important as a bedside tool to predict the neurodevelopmental outcome of a full-term infant with HIE. And you just need some little bit of training, not a very big formal training for seeing this. Next. Now, whether we can use this AEG to say that whether we want to cool this baby or not. When the TOBY trial was being done, they were using AEG as one of the inclusion criteria to say that baby should be cooled or not to cool. I would say that if you have an abnormal EEG tracing, definitely use that as a criteria for cooling, especially if you have a doubtful situation. However, this itself has a poor association between AEG recorded within 6 hours of birth and early MRI finding. And suppose if you get a normal AEG and baby is not okay and you don't cool that baby, that's going to be disastrous, and you're going to actually take the benefit from the baby of cooling and its benefit. So I would say that Don't please delay in commencing cooling just because you had a normal AEG. It could be a false negative. And so don't put it like a stringent criteria. It can be an additive criteria from your clinical, your pH, your Apgar scoring. That's what I would say for a HL.
Thank you, ma'am. Thank you. Dinakar sir?
I think so. She has done everything. She has told in brief, detailed, almost for 12 minutes. Excellent, beautiful. I think so. There is two more questions regarding HIE. Previous people have asked. I think so. We will answer. Go to the next, Prashant. Excellent.
Yes, sir. What are the limitations of amplitude EEG? Over to you, sir. Amit sir.
Can you hear me? So I think that was a great overview by Dr. Monica on the on using amplitude integrated EEG and in HIE. I think over the next few minutes, I want to talk about some of the limitations of amplitude integrated EEG. I think some of the limitations that I'm going to talk about, could you go to the next slide, Prashant, please, are actually pertain to any form of EEG. So, EEG, so amplitude integrated EEG, if you remember, is derived from EEG. Two channels of EEG are processed, they're filtered, rectified, and then compressed to give you an AEG signal. So anything that impacts EEG will also impact AEG. So some of the things I'm going to talk about are going to overlap. But it's important to remember that EEGs measure cortical activity. They're not going to pick up subcortical structural activity. So, for example, in this picture here with a baby with deep nuclear gray matter hypoxic ischemic injury, where on this T1 weighted image you see the high signal intensity in the thalami here and in the putamen and globus pallidus, you're not likely to see the impact of this injury on your AEG. Now, you may have some changes in background activity, but if there's seizure events that are coming out from subcortical structures, they won't get picked up on EEG. Similarly, if we talked a lot earlier, one of the panelists discussed the impact of medications and drugs. I think Dr. Jafar was talking about it. They will all impact EEG, and so they will impact AEG. So you will get diminished amplitude with medications like morphine or phenobarb or benzodiazepines. You will get depression in your amplitude. Surfactant is interesting because as Judy had shown, when you give surfactant, there is a transient suppression of amplitude that is seen on the EEG, there's different hypotheses as to why that happens. One of which being that surfactant drops your pulmonary vascular resistance, so it increases your compliance very rapidly. There's a drop in your pulmonary vascular resistance and a change in blood flow across the patent ductus, potentially stealing blood away from cerebral circulation into the lung. That may transiently decrease perfusion and cause depression in your amplitude. So that's a potential mechanism for surfactant. There's currently studies going on comparing different surfactants and their impact on AEG. Artifacts have also been well described. I think again it's true for any artifact that will impact EEG. So your high impedance, if you have injury to the scalp or swelling on the scalp, you're likely to get artifacts. Interference from other equipment around. EKG or ECG artifacts sometimes will come through. So it's important to try and capture ECG traces, as Dr. Monica mentioned earlier. But again, these are inherent with any kind of EEG recording. I think the other thing I'd like to mention in terms of electrode site is when you're doing EEG monitoring, I think it's important to keep a good eye on the scalp, especially in babies who have had vacuum extraction of forceps, where you may have injury to the scalp or skin. When you're applying electrodes, you should probably have the nurses either take a picture of the scalp or just to keep an eye on how that skin is, because most of these electrodes can cause some irritation, although the hydrogel electrodes are very safe in that regard. The other thing to remember is that the amplitude integrated EEG specifically has leads that are in the central parietal region of the brain, which is just on top of the sensory motor cortex. Now, if you have a seizure that is short, we did a study here looking at comparative EEG versus amplitude integrated EEG monitored simultaneously, and found that a lot of short seizures, short bursts of under 60 seconds, will sometimes be missed on the AEG just because it is so compressed. The other thing to remember is, of course, if you have a frontal seizure or an occipital seizure or seizure elsewhere in the brain, so if you have a temporal lobe origin seizure, which are all overall less common, you're likely to miss those if you just use the C3P3 and C4P4 channel. The next a few slides are going to talk about the importance of monitoring AEG in the setting in the first 3 days of a preterm infant when they're transitioning from fetal life. So as you might imagine, a lot of these babies would have had significant resuscitation. They have immature organ systems. They're exposed to potentially, some placental dysfunction prior to birth with hypoxic ischemia. They get a lot of oxygen in resuscitation and will be hyperoxic. And then they may be, maternal anesthetics can pass through the placenta and cause depression in the babies as well. And what we currently do for these babies is monitor their vital signs. The most common ones being, heart rate, blood pressure, and saturations. Intermittent blood gas monitoring or end-tidal CO2 monitoring or transcutaneous CO2 monitoring is also available, and you can check for hemoglobin levels with your gases or intermittently on a complete blood count. What we don't have as standard care right now is a measure of what's going on in the brain, what's going on with cerebral oxygenation at the tissue level and brain perfusion and brain activity. So near-infrared spectroscopy, which is not a topic in this conference, but is an important way to monitor these babies during this transition. It gives you a surrogate marker for brain perfusion and cerebral tissue oxygenation. But the EEG is the functional component of the brain, whereas near-infrared provides you a perfusion or an oxygenation component. So if you're looking for brain activity, how is whatever is going on in the baby's physiologic environment, how does that impact your brain activity? And that's what the EEG does. This elegant study by the Dutch group, Linda de Vries and Lauren Week, actually showed that if you have a baby who's got AEG monitoring, you will see, and you see a sudden change in background, it should prompt you to check a blood gas to look for CO2 levels, because they found a sudden depression in the AEGs associated with a sudden increase in a CO2 level, which could be related to either a pneumothorax or a blocked endotracheal tube. So I think it gives you important information with continuous monitoring if there's a subclinical change in the baby's physiology. Next slide, please. Similarly, in the situation, so here's actually an example from the study that shows on the top panel the amplitude integrated EEG with your normal PCO2 levels up here on in the beginning of the trace. So this is a 38-week infant with GPS sepsis with ventilation that was suboptimal. So initially the trace looks normal, and then there's a sudden depression with a low voltage type of pattern, with then some burst suppression activity, with your CO2 at this level was over 130, and then goes up to over, stays up to over 130 for a long period of time. Remember, this is a 3-hour trace, so for a long period of time, this baby was suboptimally ventilated with a progressively low voltage trace, and then it was picked up and improved. There are some seizures over here that are actually these rises in baseline that you can see. If you have a raw trace with this, you can actually pick those up. But then as the CO2 normalizes, you get this activity back again. So there's transient changes in your EEG that can pick up some sort of ventilation problem. Next slide, please. Similarly, in a PDA, I think you can get a good idea about brain perfusion again that gets impacted. And this study actually looked at the impact of surgical ductal closure and the so-called cardiac stun syndrome or PDA ligation syndrome, where you get acute left ventricular dysfunction and drop in cardiac output and blood pressure because of the increase in afterload, a sudden increase in afterload that can actually impact brain perfusion, and your AEG activity gets depressed. If you're monitoring a baby with AEG and near-infrared spectroscopy, you may be able to pick up these end organ impacts much earlier than what your blood pressure or your other systemic monitoring may provide. So you can actually try and start the baby on some inotropic support with dobutamine, potentially early when you start to see these signs, even though your blood pressure may not be that abnormal. But I think this will tell you that your end organs are functionally being impacted, and so you can actually clinically intervene and potentially prevent those complications. I think that's all I had in this section.
Thank you, sir. Dinakar, sir.
Prashant, next question. Don't worry. The limitations has been told beautifully. Hypercapnia, only one thing, sir, everybody should remember. Hypercapnia and hypocapnia. I'll tell very fast because time is it's almost over. Hypocapnia and hypercapnia both. Everybody knows when hypercapnia is there, cerebral, what happens? Hypercapnia. So more blood will start flowing events because hypercapnia, more CO2. So brain will think there is less oxygen, and even oxygen if it is less, so more blood flow will be there. So what will happen that? So it has to maintain slowly, auto regulation will be there. Slowly it will be losing. Once it loses, what happens? Tissue hypoxia will start. Because of that, primary energy will start failure. That is the reason low voltage will come. The similar thing will happen even in hypocarbia. Hyperoxia, hypoxia, then hypocarbia, then hyper. The same thing will happen. Even see, somebody might, I think so, some people might have asked the questions. It will come, sir, you have explained in detail, and there is limitations if it is a deep seated small pathology or low electrical, sometimes we might not able to pick up. So that is one. Thank you very much, sir. Leslie, sir, it is for you. It is very not so common in India, but it is common in Western countries. Please, sir, because it's a preterm delivery and IUGR babies. Leslie, sir, it's for you.
Neonatal syndrome. Over to you, sir.
Yeah, as Dinakar has already pointed out, we don't see neonatal abstinence syndrome in India. Most commonly in a developed country where the mother is a substance abuse. As a result, babies get exposed to a good amount of opiates in utero. As a result, the baby could be growth retarded, baby could be born premature. So when we monitor clinically, when we see these babies, they can have a withdrawal symptoms, they have a seizure-like activity, and these seizure-like activity many times poorly correlates with the video EEG. So the places they have a neonatal abstinence score to document what is the score, and based on the score, the treatment pharmacological interventions are considered. We don't see, and I have not seen so far any neonatal abstinence in India. So basically, the first pattern which is given is a normal EEG pattern, and that is the continuous pattern, and we see a regular sleep wake cycle here. The cyclicity is preserved here. But a baby which with the neonatal abstinence syndrome, if you see here, classically, first thing, there's loss of a sleep wake cycling in this pattern. It is a discontinuous background activity. And if you see characteristically, these are the low voltage complexes. These are not, and if you're seeing, there's a rapid upstrokes are there, and if you can see here, there's a multiple rapid upstrokes are there, and in a compressed EEG, you can see this rapid upstrokes are there. They mimics like seizures, but they are not seizures. As Dinakaran has pointed out earlier very clearly, as well as the Dr. Sidhu has also pointed out, if it is a dome shape, then only it is a seizure. If it is a not dome shape, it is not seizure. So this is what we see: a low complexes, a low voltage complexes, and this is more towards a mature brain. And here, if you see, maybe appearance of a sleep wake pattern is there, but they are again not very classical of a normal EEG here. So this is a classical pattern for what we get in the neonatal abstinence syndrome. Again, this could be a term EEG baby here, and this could be a totally absence, the sleep wake cycle, discontinuity, and low voltage. And this will help us, in addition to a neonatal abstinence score, to say that this baby's patterns are abnormal. If this baby's patterns are abnormal, which means that this baby requires a pharmacological intervention. And I think that much I can able to explain based on this, the EEG patterns. Anything else, Dinakar, you want to add here?
No, it is very rare. I have not seen in my life even one case. So I don't have experience. Only one thing what we have to learn is upper border is also rising more than 10, and it is continuous. It looks like a SWC, sleep wake cycle, but it is not. So this is the only thing I learned from the textbooks or in the journals, but I haven't seen even one case. So I don't know anything about this, Leslie. So, but we can use, because usually any mother is receiving the drugs or anything, withdrawal is there, usually develop either IUGR or SGA or low birth weight babies. So we can do use, because sometimes these babies are not developing physical convulsions. Clinical convulsions is not there. So it is wise to use AEG in these cases. And how it looks, because it's very important, because those babies will have some amount of cognitive dysfunction. Okay, over to next question, sir. Sidhu?
Yes, sir.
Amplitude EEG in IVH, Sidhu.
Yeah. See, as we all know, IVH is quite common in premature children. First of all, as explained by Dr. Judy, prematurity, what we see more commonly, it is the discontinuous pattern, and there is a loss of sleep wake cycle, and there is increased depression per se. Whereas if we observe increased discontinuous pattern in the first few days of life in a neonate, which is premature, then we have to suspect intraventricular hemorrhage in them. Here, the background history gives a significant importance. The reason being, as we saw a case scenario where Dr. Jodi told us the baby on day 5 of life was normal. On day 5, the baby developed bradycardia hypotension. They observed there was more discontinuous pattern observed in the EEG, which correlated well with the intraventricular hemorrhage seen bilaterally. Okay, coming to the cycle pattern, if you see the number of births per hour in a neonate which is premature will be more if there is a intraventricular hemorrhage. Normally, we see less than 100 births per hour. If we are seeing more than 100 births per hour with inter-burst interval less than 30 seconds, moreover, it signifies intraventricular hemorrhage and the prognosis is guarded. Coming back to the literature, where we can say a positive predictive value, if we assess a low voltage discontinuous pattern with a burst suppression pattern with increased bursts more than 100 per hour with a decreased inter-burst interval, then the positive predictive value to predict a intraventricular hemorrhage in a preterm neonate is 100%. Mind you, here we need to understand at 26 weeks what is the normal pattern, because in neonates we tend to have increased discontinuity, loss of the seed break cycle and artifact like picture where we tend to think as seizure. Moreover, we have to have a lot of suspicion to suspect intraventricular hemorrhage, thereby understanding discontinuous pattern. Next slide please, Prashant. Yeah, here you can see the density of the pattern or the continuity is comparatively less even in the burst separation pattern. Next slide please.
Prashant,
this is what I wanted to highlight. Moreover, we will be interested to understand the inter-burst intervals. The number of bursts will be more than equal to 100 per hour, and the inter-burst interval will come down less than 30 seconds. This is one of the pathognomonic feature which signifies intraventricular hemorrhage, along with loss of discontinuous pattern, loss of sleep-wake cycle, with positive predictive value of 100%. And we need to have a strong suspicion. And as rightly pointed out by Dr. Dinakar sir, it is better if we have the images saying what kind of premature child we are dealing with. We need to have a pattern of 26 weeker where already we have seen the discontinuous pattern. If the discontinuity is more compared to a normal 26 weeker, then we have to suspect intraventricular hemorrhage in such neonates. Just comparing it to a term child or a 30 or 31 weeker, the significance of intraventricular hemorrhage will be lost in these neonates. Thank you, Prashant. Over to you.
Prashant.
Yes, sir.
I think so. We will ask this question. We'll only in 5 to 10 minutes we'll finish all these questions because there are so many people are waiting. Sir, because interburst and other things we're going to talk in the next session in detail. This is a beautiful questions people have asked from the last session as well as even today they have asked many questions that we'll try to rectify. So Prashant, you can ask. MK means Monica. AM means I think you know. Okay, Amit Mathur. JK means Jafar Khan. LL means Leslie Lewis. SC means Great Sidhu. Okay, go ahead.
Yeah. First question: does sedation and muscle relaxation affect the interpretation of amplitude EEG? Dr. Monica.
Monica, we are not able to hear you.
Unmute, ma'am.
So, you know, the background amplitude can be altered by many medications. And especially we should know that when we are giving hypothermia, the half-life of these medications, what we are using is going to increase. So this is going to be a prolonged and longer effect. And especially what we are using like chloral hydrate, or if we are using any kind of anticonvulsants like benzodiazepine or barbiton, they are going to inhibit the EEG amplitudes. So this we should know. And since the inhibitions are quite transient and for less time, and it's not much. But if you're using like a very high dose of fentanyl or we are using a very high dose of midazolam, this inhibition is going to be much more and much prolonged. So whenever you are interpreting any AEG, please don't interpret before 60 minutes of the medications, whatever you have given. So wait for that much time so that the effect of the medication should go away. And this time might be increased if you are also having an hypothermia, because half-life of the medication is going to increase. Having said that, if you are giving phenobarbital and there is a severe depression and this depression is lasting for a very long time, don't contribute it to be only because of the medicine. It could be because of the underlying brain problem also. So each case would be different, and we should know how much is the effect. I hope I answered the question.
Thank you, ma'am. Second question is for Amit sir. EEG changes in hydrocephalus and recording, are they same?
In post-hemorrhagic hydrocephalus, as the ventricular size increases and potentially your cerebral perfusion pressure changes, you may actually see changes in your amplitude. I think in these babies, it just reinforces the need to monitor these babies, not necessarily continuously, but over once a week, six-hour recording, to give you a trend that you can correlate with your head ultrasounds to see whether your ventricular index is increasing in size, how is your AEG amplitude looking, and if you start to see abnormalities in AEG. So the Vienna group, Monica Olishar and Clever Mass published a case series where they showed depression of EEG as your hydrocephalus got worse. And you ideally should intervene before your EEG gets too much away from baseline.
Thank you, sir. The third question is for Dr. Jafar Khan. The cost of EEG setup.
Yeah, the cost of EEG it is not very economical. What they quote and what they give could be around, maybe I think around 20 lakh for a single unit. Yeah.
Okay.
And then there's the cost of the electrodes as well, right?
Yeah. Cost recurring cost of electrode, that needle electrode costs around 500 to 700 per patient. Then hydrogel is same. No, actually that needle electrode much more. It is maybe 1100 per piece, and that hydrogel is around maybe 750 rupees. Okay, so there is a recurring cost is also there.
Prashant, I want to add one point. Would you mind?
Yeah, please.
Yeah. So sorry to differ, Jafar sir. I would say I'm in a medical college right now. We have got something called VGST scheme. I think Leslie sir will be knowing about it. I would preferably say that unit like us should have it and make it cost effective in terms, because the prediction and the usage is quite good with this machine. And as you rightly said, the recurring costs are there in terms of electrodes, which can be reused if we have properly maintained them. But the usage right now in terms of asphyxia, for example, in a place like Bijapur, we see daily around 5 to 6 admissions per day with the perinatal asphyxia in a term unit I'm talking about. Okay, in such scenario, to explain the prognosis, to explain them the predictability of the outcomes and neurological, I think this machine will definitely be cost effective, provided we do a good work. I think NNFK, I request Prashant and Dinkar sir to kindly take up one study with all the units in terms of cost effectiveness and the usage of EEG in center like us. Hope it's taken well.
Yeah. Thank you. The next question is for Leslie sir. Seizures in amplitude EEG. Can you please clarify?
Yeah, I think it's been discussed many times in the last two classes. Again, for the benefit of our participants, when we reading the EEG, I think we first read describing the background pattern, discontinuous pattern, as we repeatedly said, more towards preterm babies, but as a term baby, it is a continuous pattern. Describe the cyclicity as the baby becomes more mature. The cyclicity cyclicities become more evident. That is the sleep-wake cycle. And on top of that, describe the seizure activity. In fact, the pattern recognition. And I think already mentioned the current sign of a dome. So I think if the good background pattern is there, cyclicity is there, plus you're getting something repeatedly, something like a dome, like a pattern, which is more towards the where upper border is elevated, the lower border is elevated, which is the classical seizure. And has been already mentioned how to differentiate from the artifact. I hope this question answer. Yeah, I have answered the question.
Thank you, sir. Next question is for Sidhu. What are the EEG changes in structural anomalies?
As per my knowledge, Prashant, I feel there are no changes in EEG in structural anomalies to the literature I have gone through. If Amit sir and Monica ma'am can add anything, I'd be happy to listen.
No, I think you're right. Like there is no specific changes which will, you can say that this change is there, so this kind of structural abnormality is there. But definitely when you have a structural abnormality, there would be a seizure activity, or there may be, brain activity might be inhibited, and that changes you might see as an abnormal EEG activity. So that would just tell you that something is not okay there.
Oh, not okay with that.
Yeah.
Thank you.
Yeah. So anybody would like to add anything? Amit sir?
No, actually, I agree with Dr. Monica. I think the majority of developmental structural anomalies are at high risk for seizures, and I think those are the ones you'll be looking out for. A lot of these babies will present with apnea, which may be actually tonic seizures or subclinical seizures. So I think otherwise, EEG changes are usually non-specific.
Yeah. Moving on to the next question. This is for Dr. Monica. How to reduce artifact, especially due to heartbeats interfering?
Yeah, we talked about artifacts a lot, and we know that peak-to-peak amplitude might get affected because of these artifacts. And I would say that, first of all, the main artifact which could be is due to the impedance. So when you are preparing the skin, you should prepare the skin properly. You should use a proper gel, and you should remove the meconium or blood or whatever there, so that the impedance is the least. Plus again, then muscle activity may be an artifact which I talked about in the previous thing. So you should try to choose a place where this muscle activity is the least. So that's why you take C3, P3, C4, P4 areas. And then the artifacts would be because when the two the electrodes are placed quite near to each other, or they get displaced. So you should have a proper measurement where you know that you are the distance is well maintained, so that the artifact is less. And then the ECG, with the pulse, there might be an artifact because of that. So you should be running your ECG with your EEG, and you will see that whenever you have an abnormality in the EEG, which is because of this, you will be able to see that it will correlate with the QRS pattern. And that's how you will be able to differentiate whether it is something abnormal in the EEG or it is due to artifact because of the ECG. So that's how you will be able to do that. And also, when nurses are doing any kind of procedure and they are moving the baby or doing something, then they should be putting it into the system that this is the time when they have done it. So that we know that this is an artifact and not any abnormality which is going on. If you are having a high frequency ventilator or you are having a ventilation, you should try to make that all the tubings should be quite away from the baby head, so that they should not be the ones which would be causing an artifact. So that's how you will be reducing your artifacts.
Thank you, ma'am. Next question is for, next question is for Amit sir. At times there is high impedance. How does one reduce the impedance?
Yeah, so I think Dr. Monica mentioned skin preparation is probably the key thing here. So making sure that the skin is prepped and scrubbed appropriately prior to. I think spending a little bit of time before you put the leads on initially, I think is important. Using that new prep and the gel and using a Q-tip or some sort of cotton tip swab to clean the skin, wiping it dry, and then putting the leads on. And then, during the recording, it's sometimes your impedance will get high, and what happens is the gel starts to dry. You can put a drop of water or saline there. Actually, water is preferred to actually get the contact going again. I think with babies who have a lot of hair, I think they are the ones that cause more problems. So, but I think initial skin prep, or if you just can't fix it, you can take that individual lead off if it's one lead causing a problem and reapply it. I think that's the best way to address it.
Thank you, sir. Moving on to the next question. How to differentiate HFOV artifact during HFOV ventilation? Jafar, sir?
Hello.
Yeah, please, sir.
Yeah. So whenever we are using high frequency ventilation, so we need to note the upper margin of the our trace. If it is having more than 25, and if it is having more frequency that is matching with our high frequency ventilator, so that we can say that it is because of high frequency machine, not because of the AEG. So this the frequency rate we can differentiate with the activity from the high frequency ventilator. Yeah.
Thank you, sir. Thank you, sir. Next question is for Leslie, sir. What's the jury on treating the electrical seizure activity on CFM?
Prashant, is it means that there is electrical seizures activities there, but there's no clinical seizures, so
yes,
need to be treated or not?
Yes.
Yeah, I think it depends on the maturity of the baby, depends on the underlying conditions of the baby. If the baby might be having a metabolic problems, probably I will consider treating the metabolic problems before I start treating the electrical seizures. But if there is a premature baby, possible etiology is IVH or something else, or it is a term baby, asphyxiated baby, undergoing a hypothermia treatment. Obviously, we know that it is because of the underlying, the hypoxia could be the seizures, and they may not be a clinical seizures. In that circumstance, the showing electrical seizures need to be treated. I'm not sure the answer is right. I want the input from Sidhu, Dr. Monica, and Dr. Amit.
It's a very gray area, sir. I think we'll start with Amit, sir.
Thank you. Well, I think the one thing that is there's very little controversy about is if you have subclinical status epilepticus, everybody will agree that they need to be treated. Well, if there are short runs of 60 seconds or less kind of seizure events, otherwise well-looking baby, especially in the preterm population, I think there's always this little nervousness about giving them, over-treating them with phenobarbital, which we know has deleterious effects on development. So I think I completely agree. It's a gray area, but at least in the US, the standard is if you see a confirmed seizure, even if it is just subclinical, that you load with phenobarb, and then you just watch what happens.
Yes, sir.
Yeah, I would agree to that. I think the clinical status of the baby is very important. If you have a background that he's really asphyxiated baby, and he might not show a clear clinical seizure, then you would definitely look at the seizure activity in the AEG and would go ahead and treat, because otherwise it might cause a bad outcome as such when already baby is suffering. But at the same time, we cannot be overloading and causing side effects of the medications by themselves. So balance and case to case, it would be, I would say.
Dear panelists, can I add some more thing, please, if you don't mind, Prashant?
Yes, sir. Yes, sir. Please go ahead.
Okay. Leslie, I am not with you. Monica, I am not at all with you. Amit sir, I am not at all with you. I am very sorry, sir. In this regard, Sidhu is escaped, already jumped and put on Monica.
No, sir. Sir, I wanted to share my experience, sir. If you give me 30
Okay.
seconds.
No. Okay, sir, it is not like this, because there are more than 19 articles regarding this. 19 articles regarding this, whether to treat or not, whether jury. Beautiful question somebody has asked. Sir, that is the reason AEEG will help us. That is the reason, if everybody sees the clinical seizure and treat, then what is the use of AEEG? Then if we have the AEEG, there is subclinical seizure is there. We are having 1, 2, 3, 4, whatever the medications you are giving, all those medications will work. Somebody has asked how long it will work that after giving the anticonvulsants. Sir, if you give benzodiazepines up to 1 to 2 hours, or if it is in a term baby, the normal activity will come back in 2 hours. Some babies 3 hours. Suppose if it is a preterm baby, up to 6 hours. But after 6 hours, it should come to normal. If it is not coming to the normal, either discontinuous burst suppression or continuous, there is some pathology is going on. Look at the seizure or something else. That is the reason AEEG is very significant in this. If you will give phenobarbital with levetiracetam, and outcome they have studied for 5 years, 3 years, 2 years. So it is very excellent. 19 articles I read regarding this. Beautiful
I agree.
outcome.
Dr.
Beautiful
Dinakar,
outcome.
I think your point is well taken for full-term babies. I think for premature babies, I completely disagree. I don't think we can define seizures in preterm babies well right now.
Sir.
There's a lot
That
of
is the
controversy about that.
Yeah. So that is the reason in preterm babies, I kept that chart. We are using it. And one more thing is, next question will come, sir. Then in the last question, it will be the answer. You will get it, sir, in the last question. Okay. Next question.
Yeah. The role
Prashant,
of
I want to add only one point. Anyway, next question is mine. Dinkar sir, initially when we had this machine at Bidri Hospital, we were fascinated by that orange color. Every time we used to say orange color, our sister used to end up saying like, sir, seizure is coming, we have to load it. Okay. One fine day, we usually come across babies whose abgars are less than 3, as rightly said by jury madam. 1 minute abgar will be 1, at 5 minutes it will be less than 3, 4, such kind of babies. And they take around 3 to 4 hours to come to us. By then the heart rate will be less than 60, saturation will be 60, 70. We end up ventilating them. The child will be continuously seizing. Once we load with phenobarb, they will be settling down. We end up giving phosphonate as well. Ultimately, when we put on CFM, we continuously started seeing the orange pattern, and every time we ended up giving anticonvulsant, every time, because treating every anticonvulsant subclinical seizure. At last, I had left with no other choice other than Medas infusion. When we retrospectively went back and saw data for the 10 babies which we had cooled in such scenarios, then we started thinking that do we need to treat all them? Then we understood the importance of marking and documentation, as rightly said by you in the previous slides, that each and every activity which the baby comes across in terms of artifacts should be taken care of. And I think we need to work more in terms of whether to treat all subclinical seizures. I'm not in favor of it, even in term babies.
Okay, Sidhu, there are just around 3 o'clock. I think so. I have sent some articles to you.
Yes,
whether
sir.
AEG before HIE, whether to treat or not, question and answer beautifully explained.
Yes, sir. Yes,
I have sent 2 articles at 2 o'clock or 3 o'clock.
Yes, sir.
Beautiful.
Yes, sir.
You read it, and it is a review of articles he has given.
Yes,
and
sir.
in that, whatever you asked, yeah. Next.
Dr. Dinkar, hi. So
actually, I did not say that. That's why I specifically said that if the baby is really asphyxiated and you have these subclinical seizures, you should go ahead and treat it. But if you are not, if the other, it's another case, then you should be looking at clinically at the baby. That's what.
Yeah, Monica, that is the reason. In that article, if you will read, you will get an overall picture about the Sidhu's question. Okay, next question.
Yeah, the role of amplitude EEG in cardiovascular surgery.
Yeah, basically post-surgery we are discussing, or prior to surgery or during the surgery. Yes, definitely amplitude integrated EEG has got a role. What we are looking for is any hypoxic changes per se during the procedure, as they'll be on the heart lung machine. Basically, we look for the low voltage pattern or continuous low voltage pattern, which is again suggestive of hypoxic respiratory failure. So I would say that EEG is definitely useful in cardiovascular surgeries for monitoring hypoxia.
Okay. We'll move on to the next question. How surfactant administration will affect amplitude EEG? And can you please explain burst suppression and continuity? Over to you, Amit sir.
Yeah, so I actually mentioned this briefly when I was talking about surfactant earlier, but I can repeat it. I think the issue with the rapid drop in improvement in compliance results in a sudden increase in pulmonary blood flow. And since the duct is open in most of these babies, you will get a systemic steal that will go into the lung, and there may be a steal from the cerebral circulation and cerebral blood flow, and as a result, your brain activity will, your amplitude will transiently go down. I think that is the current one of the hypotheses of how surfactant works. Now, some of the surfactants, there are several on the market, but some of them claim to work much faster than others as an advantage, as a selling point. But maybe that's not as much of an advantage if it's working too quickly. And there's also the setup for pulmonary hemorrhage that can happen with a very rapid change in compliance and blood flow into the lung. In terms of burst suppression and continuity, I think these are concepts that are looking at if you look at the EEG on these babies, what is the interval? If you look at the intervening period between the bursts, so there's a spurt of activity, and then there's a quiescent period, and then there's a spurt of activity again, and that's where the spectrum of continuity, which is the interburst interval, is shorter and shorter the more mature you are and the healthier you are. So the more mature babies have very frequent bursts of activity, which is what the interburst interval is small. In babies with injury, for example, severe hypoxic injury, or in preterm babies, you have a discontinuous or a burst suppression period where the interburst interval is much longer. And if you look at the period, the quiet period between bursts, in burst suppression, there's almost zero voltage of activity. So your baseline is completely flat, and then you get a burst. Whereas in discontinuous, you will have some baseline activity. So if you look at the AEG trace, your lower margin in burst suppression is almost a straight line, whereas in discontinuous trace, you can actually see some low voltage variability. So I think that's the difference. So the spectrum between discontinuity, burst suppression, discontinuity, and continuity is mostly based on what's happening at your lower margin. I don't know if that makes sense.
I want to ask Dr. Amit one question in this, that when you're saying that, because surfactant is improving the compliance and causing ductal steal increase and reduced blood flow to the brain, so do we have the clinical studies which would say that they have a worse developmental outcome? Do we have that, or we're just speculating that?
I think it's, yeah. I think that's that. I don't think we've actually studied this. So this is an anecdotal experience where I had a baby with near infrared spectroscopy on the brain with EEG and following surfactant, and there was a drop in your near infrared spectroscopy and your amplitude integrated EEG, and the only way we could physiologically put it together was this transient, decrease in cerebral blood flow. The problem is that I don't think anybody has looked at it. It's a transient phenomena. that can last for 20 minutes, 30 minutes, or an hour. And it just depends on how the baby's cardiac output actually handles it. Impact on long-term outcomes, I don't think there are any studies.
Would it be because like you are just intubating before that, and while you are intubating, you might be causing, disturbance and hypoxia? Would it be because of that?
Sure. I mean, there's, the case I'm describing was already into an intubated baby. So we had a study protocol where they had EEGs and spectroscopy being monitored. And when they got surfactant, we went back retrospectively and looked at it. So so that's how we found it. But clearly it's not been systematically studied.
Okay, thank you.
Thank you, sir. Moving on to the next question. Should amplitude EEG determine which neonate to cool? Dr. Monica.
Yeah, I think I talked about it, and I talked about that Toby trial. They were taking it as one of the marker to cool or not to cool the baby. And it has got pros and cons. And we should know again where we can use it and where we cannot. Because if you have definitely an abnormal EEG and you have a doubtful, because always you don't have all the very clear-cut criteria to cool the baby. So if we have something in a gray zone, and if we have on top of that an abnormal EEG, definitely it will help us to decide to cool that kind of a baby. However, if we have a baby again who has a doubtful criteria and then EEG is normal, I would say I would err in cooling that baby rather than not to cool the baby. So it will be something like, it can help to, if a normal EEG is there, it will help to say yes, but a normal EEG would not help me to rule out not to cool the baby. That's how I will put it. And it was well studied in one of the pediatric articles published lately, and they also actually said the same thing, because we will miss out baby, and baby might not get benefit of cooling if we have just a normal EEG and not cool those babies.
Okay.
There was a study out of University of Michigan, and actually talking about the EKG artifact, which can artificially raise your EEG, amplitude integrated EEG signal. So they have a case series. Subrata Sarkar is the first author, where they show a trace where the EEG traces much higher voltage, but it was purely because of EKG artifact, and was artificially, the baby was not cooled, and so this was a false
Yeah,
report,
false
negative.
Yeah, false negative are there. Yeah.
Yeah.
Yeah. So moving on to thank you, sir. Moving on to the next question, the last question for the session. Can amplitude EEG predict the outcome in therapeutic hypothermia? Jafar sir,
Yeah.
go to you.
Already Dr. Monica madam has explained beautifully in her talk that there are so many predictors of outcome when we are cooling the baby, like that time to return normal trace. If it returns to normal trace by 60 hours in a cooling baby, gives a good normal outcome. And if that sleep wake cycle comes early, it is also a good predictor. There are some bad predictors also there. If sleep wake cycle is never returns to appear, it gives a very bad outcome. And if the baby who is having continuous blood suppression pattern, voltage or discontinuous pattern and flat test, it gives a bad outcome for the baby even who is cooled.
Yeah.
So we can monitor the baby and we can explain the prognosis to the parents in case of birth asphyxia.
Yeah, Dr. Prashant?
Yes, sir.
It's a correct. Okay, there is a last question here. Anybody can take. Will electrolyte changes affect the AEG tracing? Number one. Which montage is best for AEEG? So there are two questions. Please, anybody can answer.
I think what I can understand is that electrolyte changes would cause a change in the ECG, sorry, and then that artifact, like whatever is the hyperkalemia, if it is going high, and then then that may be indirectly also causing a change in the AEG. Other than that, as such, directly the change in the AEG, I don't know. Maybe Dr. Amit would be able to tell better.
Yeah, I think most effects I can think of are either going to be due to the underlying cause of why the baby is hyponatremic or hyperkalemic. So if it's severe asphyxia, baby who's retaining fluid, and then you start getting seizures from a low sodium, or hypoglycemia or hypocalcemia. I mean, these are things that are likely to cause seizures. So other than what is causing the electrolyte abnormalities, which could also cause brain dysfunction, specific electrolytes, I think hyponatremia is associated with seizures.
Yeah. Yes. So which montage is best for AEEG? Means breakup. I think so. Whichever the machine you prefer, please.
You mean a 2-channel versus single channel, or I mean a standard montage? Standard montage.
That's what it means. Which montage is the best for AEEG? Means breakdown montage. Probably it is a CFM machine, 2 channels. What he wants to know.
Yeah, I think 2 channels are better than 1, especially if there's local or focal injury or unilateral strokes. I think that's a preferred. I think there's studies that have shown cases of that being better. But the standard montage for amplitude integrated EEG is C3, P3, C4, P4.
Yeah, I think so. Excellent. And is there any filtering is there? Filtering is there for pediatric AEG. Pediatric AEG, is there any sensitive and filter settings?
So the AEG filters out signals below 2 microvolts and over 15 microvolts, which is why, I think to try and capture most of the neonatal signals. I don't know if that's the filter they're talking about. But
I think so. That is the same thing. So, yeah, this question is from Japan.
I see.
And one question is from what I asked you, electrolytes is from Taiwan. So electrolytes, what you told, hyper and hyponatremia is correct. And hypokalemia is also there. That hypokalemia, both hyponatremia will decrease the voltage. Hyponatremia will decrease the voltage. Hypernatremia will increase the voltage and conversions. Potassium hypokalemia will decrease the voltage. Chloride till now nobody has studied, only chloride, because always associated with the sodium. And that's what there is one article I got it about the electrolytes and AEG disturbance. Probably next session we are going to discuss in detail. And it is a common what in the preterm baby, if it goes for severe hyponatremia, we do have seen really low threshold, then after correction slowly it comes up. Okay, I think so. Very nice, Dr. Leslie and Monica, Sidhu, Prashant, and Amit, Jaffa. Excellent, very knowledgeable input. Today we got all the, I should not tell, from almost from other than China, everybody has participated. I am not seeing any China people here because I asked Anvati who is taking care, and people are really happy and they have sent a lot of messages. I don't know why they are sending to my mobile. Okay, I told them to send to Anvati's, who is the main person. I don't know. Okay, I am not seeing any China here. What Anvati is sharing me, but Taiwanese, Japanese, and Hong Kong people are joined. Very good. Thank you, panelists, and hope so. We will see on 29th. Okay, sorry, 5th.
Today is
August
29th.
5th August.
नहीं यार थोड़ा भूख लग रहा है यार. Okay, August 5th we'll see. August 5th. Thank you.
Okay.
Thank you. Over to Prashant.
Thank
Bye.
you.
Bye. Thank you very
Thank
much.
you. Thank you
All
all
right, thank
for
you.
your time. Thank you. Take care. Have a great day. Good night. Good
Thanks,
night.
Dr. Dinkar. Thanks, Dr. Prashant,
you.
and thanks to all the panelists for
Thank
taking
you.
the time. I think it's been long, and you kept the interest alive. And thank you so much.
Thank you.
Thank you,
Thank you.
Ganesh.
Thank you.
Thank
Thank
you,
you,
Ganesh.
everyone.
Thank you,
Thank
Ganesh.
you for all
Thank
the
you.
support.
Thank you.
Thank you.